cataract and refractive surgeons of our times. He's a founding director and chief surgeon of Gulani Vision Institute. He's the global CEO of the Gulani Surgical Suites. He was a former chief and professor at the Department of Laser Refractive and Corneoplasty at the Surgery University of Florida School of Medicine. Dr. Gulani, I think this the introduction is really not necessary because the number of presentations that he has had on various international forums. He has many peer-reviewed publications to his name. The noteworthy things are some of the surgical instruments and techniques that he has developed and evolved. To name a few, the corneoplastic, the master technique for no pain PRK surgery, the sparkle no stitch cosmetic pterygium and pinguicula surgery, the color Doppler sonography for intraocular lesions. So these are many things to name a few. There are a few newer classification systems and protocols that he has developed. The 3-tier LASIK complication classification, the Gulani 5S system for advanced LASIK and corneal surgery, the Gulani planning system for stage surgical techniques, the epithelial ingrowth density classification in LASIK. And needless to say, he has had various awards and global recognitions. And the list goes on. So with this, I invite Dr. Arun Gulani today. Along with Dr. Gulani, we also have, eminent panelists and moderators in our midst for the session today. So I hand over the mic to Swapnesh to introduce our panelists and moderators for the morning.
Thank you, sir.
Dr. Swapnesh is the Honorary Secretary of Bombay Ophthalmic Association. So, and again, along with that, I invite none other than our dear Dr. Gulani Fans, Madam, the Vice President of Bombay Ophthalmic Association, and currently the Scientific Chairman of our Maharashtra Ophthalmic Society. And of course, my dear friend Vaishal, who's been instrumental for organizing this August gathering. So Swapnesh, the mic is yours.
Yes. The moderator for today's session is Dr. Siddharth Relan. I'll take this opportunity to introduce him. And Dr. Siddharth is a refractive surgeon since last 18 years and has been a chief refractive surgeon at the Laser Vision Center, Sai Priya LASIK Center, and the Hiranandani Fortis Hospital. He's done over 7,000 surgeries, and he's currently the chief clinical trainer for custom with Pulsar Z1 laser in the Asia Pacific region. He has many trainees who have taken training for the various laser procedures under him. And I would also invite Dr. Gulani Fans, Madam, to say a few words. And it's a great pleasure to have Dr. Gulani amongst us. It's a great learning webinar for the PGs as well as the BOA members.
Thank you, Swapnesh. It is a pleasure to welcome Dr. Gulani. And, Preetham had to be brief about his biodata because, we need to hear from him. But I would say that he's a great surgeon. And if you, with all the degrees, all the work that he has done, my teacher, Dr. Lahane sir, always says that how do you know as a surgeon how you are? Because when you start getting referrals of complicated cases and when people, patients and surgeons believe that you are the only person who can rectify it, then you know that you have reached as a surgeon. So I would say that Dr. Gulani's hallmark is that he clears up the mess that everybody else has created and gives 20/20 vision to his patients. If you see his photos and the work that he does, he enjoys life. He has a beautiful wife, he's a gynecologist, 2 children. So he's a guy who's an all-rounder. You should see the fashion sense. He's an icon. But most of all, he loves his patients. He really cares for them. They are his family. And he clears up the mess that everybody else has created. Of course, the mess that is created is never intentional. But, for people who have lost hope, that they would ever see again. And when they see, and when they see very well, they give a lot of blessings. And the blessings are from, in the form of Dr. Gulani, who has been an angel to them. So we welcome you again. I also welcome the panel, Dr. Siddharth Relan, Dr. Vaishal Kenya, Dr. Ramesh Shah, Dr. Nitin Dedia, Dr. Nitin Balakrishnan, who are the senior people who will be discussing, and I really thank you all. I thank Vaishal and Swapnesh for putting up this meeting together so that everybody can enjoy this feast on a Sunday. And, without saying more, I would please hand over to Vaishal and Dr. Siddharth to host the dynamic duo of Dr. Preetham Samant and Dr. Swapnesh Samant, the president and the secretary of BOA, the dynamic duo are still continuing, and we hope to have a live meeting this December end or early January. And I really thank Preetham and Swapnesh for the work that they do at BOA. Thank you so much. Over to you, Vaishal and Dr. Siddharth.
Thank you for the kind words, ma'am. So with much further ado, we open the meeting and ask Dr. Gulani to take over from here, and Siddharth would moderate the session further. So Gulani sir, please welcome. And we are eagerly waiting for to hear from you.
Sir, I have to introduce the panelists. Am I audible, sir?
Yeah, very much. Yeah.
I would like to introduce the panelists. We have Dr. R.C. Shah, Dr. Narendra Malakrishnan, and of course, Dr. Vaishal Kenia. So a few words of introduction for them. Dr. R.C. Shah has been practicing in Borivali for the last 30 years. He has done over 13,000 multifocal IOLs. He's a pioneer for iris claw IOLs, a pioneer in RHO inhibitors for corneal decompensation. He has designed a unique varifocal IOL with Dr. Kakadia and has trained many surgeons. Dr. Balakrishnan has been a cataract and refractive surgeon in practice for the last 30 years. He's a founder and chief medical director of Saideep Eye Clinic and Crystal Vision Center. And he's currently a consultant at Nanavati Super Specialty Hospital. And he has performed many live surgeries in various conferences. And I would like to mention that he has been awarded a gold medal for his exemplary services in the field of ophthalmology by IIRSI and UK SOS. Dr. Vaishal Kenia has been practicing refractive surgery since 23 years with a keen interest in corneal biomechanics and has published quite a few papers in that field. He also has the credit of being the first doctor to have installed a femtosecond laser in Maharashtra. So now we shall start with the session. I would like to start sharing the screen if it is possible. We are unable to share the screen, so I will start with a few questions. We have got the audience, we got the doctors, we got many of the residents to ask a few questions for Dr. Gulani. We are unable to share the screen due to some technical difficulty. So I will just be asking the question orally. Vaishal bhai, is there any way in which we'll be able to share the screen, or should we go ahead?
Yeah, you can. I'll make you the host so that you can share the screen.
Perfect.
Just a minute. Yeah.
I still am unable to share the screen, sir.
Give me a minute. Yeah, now you can share the screen.
No, sir, just a second, sir. I will get it done. Just a second, sir. I'm having a little problem here. Just get this done at some time. So while we are sharing the screen, I'll start with the first question for Dr. Gulani. Everybody knows Dr. Gulani, but there are a few residents over here who would like to know as to what is laser plastic. Is it a surface ablation? And if it is a surface ablation, what is it? What is the secret sauce which separates it from all the other surface ablations? Dr. Gulani.
Next question.
Yeah, Dr. Gulani.
Next question. Can you hear me?
Yes, surely. So the next question is, so what are the you have had the privilege of having done the residency program both in the United States and in India. And there are very few people who have had this privilege. So the residents over here would like to know what are the benefits and what are the differences and how can we change the residency program over here And they have a question is, if Dr. Gulani was practicing in India with the current setup, would you have been that successful, or would it have been a little more difficult for you to reach the heights which you have?
Very good. Next question.
Okay. So the next question is, with respect to the minimal residual bed in LASIK and the surface refractive, surface ablation, sir. So we have a case like there's a 23-year-old female with -7 diopters in both eyes. Topography is normal. Pachymetry of around 440 microns and an anterior chamber depth of around 3.2 millimeters. So what would be your treatment of choice? Would you restrict yourself to LASIK surface ablation on an ICL, and what would be your treatment of choice for this case?
Okay, great. First of all, good morning, India. Everybody,
good morning, sir.
Great to see you guys. I am from here, from KEM, and absolutely love to see you all. Ragini, thank you so much for the generous invite. Both you and Dr. Alhane are doing extensive work, which is absolutely commendable. Dr. Preetham, great to see you here. Dr. Kenya, thank you for organizing this. And thank you to the BOA for the invite. The way I like to teach, and that's Ragini's back, so thank you again for the generous invite. The way I like to teach is basically not to answer questions which continuously make you dependent on me. I want to free you up. I'll teach you to fish in such a way, whether you go after a guppy or a shark, you'll be confident 100% of the time. Are we clear? I want you guys to be rock stars. You're already amazing surgeons. I just want to pull you out of these boxes of, do I make a burger, a hot dog, or a taco? You're a master chef by the time you're done. All right. So here we go. My pattern of teaching today is going to be part of my master class. It's an 8-hour course, but I've brought it down to an hour. Then I want to take questions from y'all and see if y'all got the concept, and then you can punch me with every worst scenario you had, and we'll walk to 2020. How's that?
Perfect, perfect, sir.
Okay, wonderful. So I'll first take you through some case scenarios. Then I'll take you through my mindset, and I'll stop right there and I'll answer the 3 questions you asked me. Is that all right?
Perfect, sir.
Perfect. Here we go. Let me know if you can see the screen shortly.
So I will share, stop scaring, so you could share the screen. Just give me a second, sir.
Okay.
Perfect. You can share the screen now, sir.
Can you see now?
Yes, sir, we can.
Perfect. Let me know if the volume, everything's okay, because I'll be going a little. Lovely. Here we go. So the title for today's talk is Mindset and Attitude, right? I'm from here. I know all of you guys are wonderful surgeons. I'm not even discussing surgery. I'm taking you into your mindset. I'm going to teach you how to perfect every surgery, that you don't treat it like a number and your patient does the talking for you. Is that
perfect,
okay?
sir.
I can't remove the... Okay, very important here. I want to show you patients walking out of surgery immediately. Complex patients, some of the world's most complex patients who are extremely demanding, extremely skeptical, but see how they behave, because I want you to be addicted to that scenario. You cannot start driving every day, worry about the street and the bumps and all the accidents you may get into. I want you to think about the destination, all right? This is right out of surgery. Can you hear? Can you see?
Everything is perfect, sir.
All right. Patients of keratoconus with extreme complications. This patient had multiple surgeries before coming over. Look what she did with her 20/20 vision. These are videos that they send me. These are pictures they send me. They come in just to get a picture for their family, and I do let them do that with me. It's very important. It shows you how you freed them up from years of blindness. This is called the dragon in the US, in the Carolinas. There's a mountain path for the dragon's tail. Very risky to do biking and car driving. She did that on that trip. Keratoconus, as you know, my concept, think outside the cone. There are a lot of patients of keratoconus that keep calling me from here, and I'll explain to you what we need to do and what we should not do to them. And here you can see these patients into the best of their lives with their extreme 20/20 vision. All of these are keratoconus patients, from mild to extreme to what are called impossibles, all back into their lives and professions. This is one day of all extreme cases of keratoconus. How you change people's life, even like this girl from South Africa, extreme nystagmus, high hyperopia, high irregular astigmatism, told nothing can be done, came completely depressed. This is how they leave. This is an instrument I've designed to hold the eye while I do my laser plastique for her surgery. You see how they change their lives, and you see she actually went to California, did a skydiving before flying back to South Africa, and yes, 2020. All of you have, many of you, if you follow me on YouTube and Instagram, my fellows keep posting for you all because I want to show you all everyday things at my institute. So I want you to do it because I know you can. This is 8 diopters of irregular astigmatism on an over 20 cut RK where I've just finished doing her premium cataract surgery, no stitch. And I'm now removing the scar, which is perfect 8 diopters, as I know, not topographic, refractive based. And again, patients I want to show you all the time. These are patients who are sent to me as what you all call nightmares, refractive impossibles, nonsense conferences are held on these. Each of these patients should be 20/20. I want you to be very demanding on yourself. Do not use the excuse of impossible. There is no such thing as not a candidate. You are a master tailor or a master chef. Everybody goes home with something. While you're doing these surgeries, masterclass, these are the levels that I want surgeons to be at. If doctors are bragging about doing white cataracts, stupid lens stitches, vitreous playing around, that's nothing of importance or impressive as far as I'm concerned. If they're doing cataracts, LASIK, SMILE, PRK, ICL, they're just technical at that point for me. When you have empathy for the patient, where you're aiming for 20/20 all the time, now you have raised yourself to a surgeon. If you did 30 cases and you don't know their names, you're a goddamn technician. When you raise the empathy level, you know everybody, surgeon. When you raise that to artistry, every surgery done without anesthesia, with just numbing drops, no Valium, you're dancing with the patient in surgery, they're talking to you. I recently just a guy, Oprah Winfrey's pastor, he actually was singing when I was in his eye. In his eye, very important, please. That's artistry. When you take the artistic knowledge, like minuets, right, like pieces, and you can tie them together forwards, sideways, or backways to take staged surgery to 20/20, now you're a vision architect. And when you can do this consistently, 100% of the time, you're now a maverick. So that's the levels. We call it the G-star level of the masterclass. All of you know I love to show patients because to me, there is no higher accountability than a patient on camera. All graphs, all statistics is complete BS if your patient is angry and flying to me telling me what a pathetic job the surgeon did. They're all sitting in my institute. I want to make sure you guys are seeing your patients and learning from them because they are the best teachers and they are the highest level of accountability. If anyone shows you any surgery on stage and shows bravado, stop them and tell them to show you the patient. If the patient is thrilled, gets up to the beds and hugs them and it's 20/20, it's okay. If not, walk them down the podium. You do not want to see surgical acrobatics. You want to see 20/20 outcomes in every disaster that you see. Are we okay here, guys?
Perfect.
Yes, wonderful. Very important to me is keep on teaching, guys. Don't think you're just a newbie, you've just started surgery or something like that. Keep on teaching. It makes you a better teacher, a better surgeon, makes you more accountable because everybody who's coming is coming at different levels to you, right? Keep that as a lifetime quest that you have. We hold numerous trademarks and various proprietary techniques. I will answer your laser plastique technique later. These are concepts that I use in my practice every day. I love fashion. I love colors. I like to blend that into the work. Why wait till 5 o'clock? Why wait till the weekend? You're a doctor, right? You enjoy the freedom that you want to plan. You're not made to run into 4 offices, have 80 people waiting for you. Everybody's breathing down your neck and you hate everything. That's not why you became a doctor. Enjoy your day. It's your office. If you like polka dot, paint that on your walls. If you like rap music, put that in the waiting room. It's okay. Be you. And of course, celebrate your patient. These are every Friday photos if you've seen on my Facebook, Instagram that I do for you guys to inspire you all. These are every Friday patients. And when they come in, they are one at a time. I have no waiting room. You'll never see more than 1 patient in my institute at any given time, no matter where they flew from, on what part of the planet. But on Friday, they all get together, post-op day 1, and they all fly back together. It's very important to me. Again, the ambience of surgery. It's not just a surgery, remember. It's a nice feeling. It's a nice experience for the patient. Don't do it to just show off. Do it that you really mean it. To me, it's very important. I meet with the patient before surgery. I talk to them. I have doctors watching impromptu. I come out of surgery with them. It's important to me. You're watching here now, very complex patient, but I'm going to show you their comfort level. And again, don't forget, these are the world's most demanding people. They've already had many, many complex surgeries. Hear them. This is the guy from Abu Dhabi. multiple failures of surgery before he came here. Did you hear him? And my love for them doesn't stop there. That evening before flying back to Abu Dhabi next day, he rented this bike and wanted me to sit on the back of it. Now remember, he's had multiple failures. I've done an intraocular massive procedure on him, and my confidence is sitting on his bike that same evening. It's important. The relation has to be bilateral. These are patients with intense anterior segment reconstruction techniques, but watch them coming out topical, no stretcher. Watch, please. Fully conscious, talking about, and they have flown after multiple surgeries. And this is how they enter.
All right, Tracy, ready?
I'm ready. Ready to dance my way in.
None of this can happen. None of this can happen by you just forcing your staff. It only happens when you are genuinely involved. Your patients love to react with you. So the work has to be there. As I say, you cannot put garbage in a nice package. You cannot. You have to be content-wise perfect. Do not get confused by topographies and things that scare other doctors. They hold conferences on these things. It's nonsense. Here are patients with 23.5. I've corrected 38 diopters, 44 diopters, straight to 1 and zeros. Very important, please. Don't stymie yourself. You can do it. All these important, we'll talk later how we've corrected all this, but it's important for you to know that it can be done. Here's a patient who came with multiple refractive procedures. Now, what do most surgeons do? Just seeing the procedures, they talk about the bad surgeons, bad surgery, but best part, they do nothing for the patient. They stop right there. That's the wrong part. In fact, you don't care who did the surgery, which part of the world this guy flew from. I want 20/20. That's your goal. Even how you keep the topographical anomalies and work inside the eye to optically correct the vision. That's the trick. The patient doesn't care about how the cornea looks. They want perfect vision. That's the goal. You can't do stupid things like PTK surgery, work on the scar, confuse the patient's refraction, leave them blinded or with glasses and contacts. That is not success. Now, up till now, are we getting the concepts up till now? Is that all okay, guys? Yes? Now we'll show you all impromptu surgical outcomes where patients are in surgery and see their reactions. Very important, please. You're watching many things now. First and foremost, I repeat again for people who are just joining, I see. These patients are some of the world's most complex cases. They've had multiple surgeries. They're very intelligent. They've done extensive research before flying to me. These are not ordinary people, but see their reactions. Second, notice that they're all topical. They all walk out. They're all conscious, and I'm talking to them. 3, I want you to see that these cases that are told can't be done, see the reaction of these patients as they come out of their vision imprisonment that they have been kept in for years of the doctor's disbelief that they could perform. Should I repeat my sentence? The doctor did not believe that they could perform. If only all doctors believe that they can perform, the performance is already there. So watch this.
Laser plastic on your keratoconus. Can you tell any difference?
Yes, the light is clearer.
Yes?
Yeah.
Any pain at all?
No.
I'll keep going a little fast for time because I want to take your questions. Here we go, next one.
Manny, we just finished your laser plastic on your very advanced keratoconus. Can you tell any difference?
Can't believe it.
I just finished doing laser plastic on your keratoconus cornea. It's a very irregular stigmatism. Can you see anything at all?
I see an immediate difference.
Are we getting addicted, guys?
Oh my God,
Is it working for you?
From the inside out. This is fantastic.
Any pain, Hector?
No pain
What you
whatsoever.
don't want is a surgeon showing you nonsensical surgery. You want to see the patient outcome.
No pain, everything.
That should drive your surgery. That's important, please. I'm going to show you this constantly. I call this circular side. All of you have seen my videos, how I take irregular corneas and make it to a perfect reflex. That reflex translates to vision. Take any patient. This patient had multiple surgeries, glaucoma tubes, retinal buckle, multiple corneal procedures, 28-cut RK, unmeasurable cornea, but watch their reaction.
Like we just finished doing laser plastic on your very complex eye, over 28-cut keratotomy, trabeculectomy, cataract surgery, because laser technique. And we do laser plastic right now. Can you tell any difference?
Yes, I can. It looks very nice and clean and very round.
Wow. Any pain at all?
No pain whatsoever.
For doctors watching, you can see this cornea over 28-cut RK. You can see the Iridotomy here, you can see the bleb over here, very big bleb.
Large bleb and buckle.
Cataract surgery, the nasoplasty.
So do you understand? It doesn't matter how many surgeries and how bad the eye looks. I want my vision. I'm optically fooling the brain all the time. I could surely show my surgical skills to lamellar on this and blah, blah. It doesn't matter. You want vision. Be relentless in your inventions. Never accept the status quo. Never accept anybody who says they've done this for 10 years, 20 years, 30 years. In fact, walk away if someone says that. Keep inventing in your own practice. You're not small to anybody. You are really amazing, each one of you. Keep on doing stuff. All of you know this from 3 decades ago. I've been talking about these concepts without confusion. Cannot call something a LASIK complication. It's a corneal situation. Are we clear? So a smile complication is not new. It's still a goddamn corneal situation. Don't call yourself amazing because you do things like smile and all. It's nonsense. Just stay within the parameters of vision and then be amazing in 40 techniques. Don't call yourself a surgeon like a burger maker. You're a master chef. Deliver forward. Don't think backwards. Again, complications of LASIK, no big deal. All levels can be fixed, all 3 levels. Can you hear that properly?
Yes, sir, we can.
So I'm teaching you constantly, more than physical, how you can optically perfect every eye. Never PTK, never PTK. A doctor who's doing PTK exposes the fact that they don't understand optics or anatomy. They always lead the patient to a bad refractive error and they look at a clear cornea. That's not success. Are we clear, guys? Clear cornea is not a success. Refractively neutral cornea is a success, but that translates to vision. That's what the patient wants. See the circle of sight again? See the circle? You don't even need a topography. You can just see right there and you know you got it. Now let's take you through some cases where I'll show you my thought process, especially for the residents and fellows. I don't want you to ever be fearful of any situation. Remember, you can do it. All right. And you need no particular technology. I want you to be dependent on yourself. Here's a patient with multiple complications, left blinded for 60 years, hexagonal keratotomy, a surgery done during the arcade times for farsightedness though. Severe ectasia, fuchs, cataracts. You'll see now over 23.5 diopter astigmatism, 23.5, over 90 diopter keratometry. But does it matter to me? It does not. I want 20/20. No matter how tall the giant is, I'm going to break the knees of this giant. I want perfection. That's the confidence I want for y'all. All right. So first, what I do here is, if you see, is I first try to stabilize and make the cornea measurable and stable. Very 2 important words. Nothing else, or everything else is jargon. You want the cornea to be measurable and stable so you can get inside the eye and do an accurate cataract surgery. That's our goal. Everybody clear? I'm not afraid of what I'm seeing and what's going on here. That's my goal. Doesn't matter now. So first, I took intact rings. You can take Kera ring. You can take whatever's available, Ferrara ring, whatever's available in India or anywhere else in the world. And I put it around the hex gate to stabilize and make my cornea more measurable. And you'll see me do that surgery. And I brought her astigmatism down to 1.4, which is very accurate. You can see the surgery now. We'll go through it quickly.
75-year-old nurse who was
Can you
referred
hear?
to me following hexagonal keratotomy with corneal ectasia, vision of count fingers only, and Fuchs dystrophy, along with associated cataract and high keratometry of 88 with high irregular astigmatism of 23.5. I planned first to stabilize.
It has to be
and make
manual
her
because these
cornea
surgeries the
measurable
lasers cannot
in
do.
sync for future cataract surgery. Here I am using intacts, and as you can see me, I'm using her own corneal resistance to guide my intact rings in place. I'm doing this without any sharp intervention, so I don't make mistakenly any incision that can go into the hexagonal.
Patient is still
keratotomy
topical,
guts and
remember.
perforate the cornea.
We're chatting.
Again, notice these are very determined yet very careful movements of the ring, and I'm placing them so as to embrace the central unstable.
Are we getting the concept, guys?
Success
Yes,
of this
transplant is
immediately
easy. That's
reflected
a
in the
brain dead
central light
surgery. Cannot do
reflex,
that.
if you notice, which which is becoming more and more circular, and I call this the
See the circle?
titratable,
I know in my mind,
cataract
23 has
surgery.
gone down to at least
Notice
2 or
again the
3.
light
In
reflects
fact, it
now
came down to
perfect circle. I'm
1.4.
extremely pleased to
I
the
don't
point that
cross-link
confidently
between any
cross-link
procedure until
this
it's
success
stable,
is
but in this
reflected
case,
in
because I saw the
target
circle of sight, I cross-linked right there.
4 diopter astigmatism.
Look how they
Patient
dress
extremely
up.
happy,
60 years
comes
of
to us
blindness.
next
You
day to
couldn't see
meet
her
me.
face. Now look at the
4
dress up.
months after determining stability of this cornea, so we can determine accurate cataract
Now we're going for the
surgery.
cataract.
We proceed here.
This is for
Trap and blue for
surgeons
the
watching.
observing surgeons. Viscoelastic exchange. I plan my capsular excess to be a smaller size so I can see the edges between the hex K cuts and the intact reflections, and also to maintain a good lens and capsular diaphragm. I now proceed with what we call phacoplastics.
Like lensoplastic, I'll explain. All these are artistic levels
steps.
of surgery.
Like
you
you
see my
phaco
phaco
probe
is not moving at all. It's in one position. I don't want to distort the incision.
Most of the movement to maintain a stable
Because
incision.
again, you want to be very
Similar to
arrogant.
the
You want
IA
no
lens
stitches, which will
insertion
induce
here.
astigmatism,
Lens
right?
is now being
It's
placed
very
in the
easy to
bag
take a stitch.
and
You
then
should not.
gently moved into its axis. Again, irrigation aspiration. Well,
And we put a toric lens with full confidence to 2025 minus vision.
No stitch to
2025.
induce any astigmatism. So
That's
here
the
we are
ratio of
taking a
sealant.
patient who was
For
denied
traveling
her vision
patients,
for
I do
60
that in
years.
some cases, but we went through this incision.
Few minutes surgeries, 4 months apart, we have restored her vision and her confidence to give her back
She's
her
now a
life.
nurse.
She's come back to nursing and helping other patients. Here she is
Immediate
immediately after
post-op.
surgery, and here is my payback, seeing them smile and free to lead their life and help others. Once again, thank you.
So it's important to trace the culprit. Do not blame previous surgeons. Do not count the number of surgeries. I'd like to find, as a detective, the main cause of the vision issue. So when many, many doctors come to visit, they are surprised when these patients are landing. I actually am with them for hours trying to find my culprit. Last thing I want to do is waste my energy. Who did your surgery? Which country are you from? Not important. I don't want to see the notes. There's the broken camera. How do I fix it? I believe her brain can see. Are you getting my attitude? I absolutely believe she can see. I am the one who's going to limit that outcome if I am not good enough. That's how I look at it. So see how I traced her problem in this case. Her cornea still looks horrible if you see the corneal wavefront here. Do you see that? But the vision outcome is 20/25 minus. So her cornea still has the hexagonal keratotomy, Fuchs, and all the issues going on. All kinds of RK cases, no matter how many cuts there are, can be fixed in 2020. Please remember that. Here's another patient I'll take you through. Now, in this case, why did I go with this extreme scenario in my 5S system that you know? Because his cornea was down to about 100 microns thin. He had over 30 cuts, actually, 28 plus RK plus AK, all around in a circle. And all his RKs were open. And he's an oral surgeon with central blinding scarring. And my future desire is cataract surgery, because that's the end point of it, right?
This is a patient who's a
Can you
surgeon
hear?
with dense central blinding scar with crisscrossing and deep open RK cuts with high irregular astigmatism.
Again, 15
over
diopters,
15
regular
diopters.
astigmatism.
And I plan an anterior hand lamellar.
Never do a
plastic
PKP.
here.
Never,
Judging
unless
the
there's
RK
full
incisions are
perforation. I
open
want
and
your
very
mind to
fragile,
resist
cornea less
doing a
than
surgery that
60
doesn't give
microns.
vision.
See the incisions here in high magnification.
Full
Open
incisions
as a
now,
done
still
yesterday,
open,
very
40 years
deep and
later.
crisscrossing. So
I
have
never
to be
use
very
sharp blades
careful
in the cornea
because I
ever,
have a
but in
danger
cases like
both
these, which are
anterior to this blade
hypotonic,
where anything
low
can split
intraocular
open
pressure, and the
posterior
cuts are
where
open,
literally
I want to
go
gently go with the
inside
blade,
eye.
because I don't want
If I make
levels,
any
I want
mistake
one
of
plane.
using wrong pressure or being in the wrong plane. So you now
And the front
taking
cornea
off
doesn't
the
matter, right?
scar
And I'm
from
now peeling the
multiple
scars
RK
that have been
incisions,
sitting for
again
over
using
30
my
years
corneal
here.
resistance guided technique. I'm now using a donor.
So we cut this cornea and using the anterior lamellar, it's much thicker than what I need to build my cornea
I'm
for future
actually
surgery.
gathering 3 pieces of the
And
cornea
again, I'm
recipient
resisting the
donor
urge to just do a
and
stitch. I'm doing my
arranging
anti-torque
in a
suture. It's
closed fashion.
difficult because I'm
My
going through
anti-torque
cuts.
suture
And I
usually
want
allows
to
for it
bring
look
everything
like a
together
star,
with
but
least
this is
distortion.
asymmetric because
There
of
it
the
is,
way
still
we
the
had
star
come out
shape.
in different areas. This is pre and post and then.
And then I followed with cataract 3 months later. Again, no stitches, toric premium lens. Done. Here's this oral surgeon. Look at his reaction right out of cataract surgery. That should tell you how much these people are suffering. I just did the second eye, same result. A quick summary of how we landed. So even modern technology that you have to use, and this is again for new doctors too, resident fellows and stuff, use them, but use them to the highest level. Don't just put in some new technology and call yourself a pioneer. That's not a pioneer. You're just the first guy who got to the grocery store. That's nothing important. If you're a pioneer, the industry must come to you and say, can you please use this and tell us right or wrong? All right. So here, this is the DexiQ, which is an intraocular steroid microsphere that we've used in many patients, and you don't need eye drops anymore. You can see that me shooting that little microsphere inside the eye. You can see here using the Dextenza, which is a lacrimal plug that has a steroid in it in patients who are traveling when I've done their correction. And I put that in and it helps them a lot to get away from medical drops. So that's the ratio sealant I use in patients who are traveling post-RK for no stitches. I just don't want stitches in anything. A quick brief look into what I expect you all to know in surgery. Again, I repeat, LASIK, SMILE, PRK, ICL, cataract, lowest level of skill. Lowest level of skill. Raise that into artistry and then minutes of architecture. And now I want you to be where I want you to be. This is using the anterior lamellar techniques for intacts or Cara ring placements to monitor or irregular corneas to straight correction. Lamellar techniques, I want all of you to do. Fellows, residents, it takes nothing much. Get an eyeball from the eye bank, sit inside, do a $20 tooth blade and do it. Practice your suturing. Do I never want you to suture ever? Just a star suture I want you to learn. Very important. Never do a PKP. Pterygium should look gorgeous next day in the mirror. You'll all know, you'll have read my book. Very important. These are day one appearances. Cataracts, be a master. Be a master. Doesn't matter how difficult the situation is. Do not do acrobatics in the eye. Do not use instruments that are not needed. Just be fully dependent and confident on yourself. Right? Those are ICLs coming out in complex cases. I'll show you later. Piggyback lenses. So these techniques are so easy to do. All of you are very skilled, but how and when to do it is the part we're discussing today. Again, patients like these, when they fly to me, these technologies, doctors are very proud. They advertise, we use the new technology, we use the Vivity lens, whatever. Technology is always good. The problem is the doctors are not understanding the sequence or which eye to deserve for which technology. That's something we'll talk about today. So again, you can take patients and free them up no matter how complex. So this guy is a nurse in Boston. Very, very important. We'll go through all these case scenarios. Even complex, one of the most complex intact cases I have ever done. 100 micron cornea, fully scarred. But look at my mindset. I'm resisting a PKP. He's a young, dynamic guy. He's a painter. He travels up, long heights, and he works that there is a lot of weight he has to carry. So you want to resist. I could have done a lamellar surgery, but my intention here was directional stability, which is intact. But because the second ring was still there up in the eye, I compressed the lower cornea, brought into regularity, and we are done. You can see this case scenario. See the thought process here. Patient who's had surgery elsewhere with the pseudo-phakic multifocal lens. Doctor had a hyperopic surprise, did multiple PRK, PDK. Patient now has a scar and wants to sue the doctor. With a laser plastic, got the scar corrected, put a piggyback lens, straight to 2020. Patient from Egypt had surgery all over Europe, multiple for keratoconus, doesn't matter. Refract the patient, take them straight to vision. Here are patients with multiple scarrings with RK, can be corrected. No need for transplants. Now here, after I discuss this case, I'm going to stop and take questions. I want you to understand my mindset, guys. So here's a patient with keratoconus, had a premium cataract surgery with an excellent surgeon in the US, ended with hyperopia, of course, had high case of keratoconus, has a central anterior scar, has a premium lens in place, and the doctor, following his own protocol, did the next step, is the ag capsulotomy, which is not a good idea because the lens can't be exchanged anymore. Patient very, very angry. He's also a potential pilot. He now has no distance vision, no reading, hates everything, and has paid for premium surgery, right? So improper. So what we did here, I'll quickly go into this scenario just for the logic of it. Most surgeons he saw in the country, in the US, said, oh, this is fine. It's a wrong thing what's happened. Well, I'm a great surgeon. I can remove this lens, do a vitrectomy, then I'll stitch the lens in. There's a new technique. But none of that I can approve because the mindset is wrong. Will that get you to 2020, doctors? Never. You've now disturbed the vitreous, you now played with the sclera, you now cause inflammation, and you cause a barbaric surgery in the eye. It doesn't matter what you can and cannot do. That's not important. I want 2020. So see how the mindset moves. In my mind now, I'm now going to pick up all of these bad things that the patient has. I call that like picking pins in bowling, right? Remember? So what are the issues here? Patient has high keratometry, central scar, hyperopia, pseudophakia, and astigmatism. The one surgery that can correct all these errors is myopic laser ablation. Are you guys with me?
Perfect.
So see how I took all his anger. All the fellows and surgeons who were visiting that, they were surprised because they were wanting me to show my skills and I'm going to do this and that. And they were surprised to see how I brought it down to a simplicity here. That Mr. Smith, I'm just giving it a name. These are your issues. Your doctor did a good job enough, but these are your issues right now. And my one surgery that will correct all of this, because remember, corneoplastic means 5 filters: least interventional, cosmetically excellent or elegant, visually promising, brief and topical surgeries. Every surgery I do must pass through these 5 filters. It cannot be barbaric, cannot be crazy in the eye, cannot have no potential for vision. All of it is visually oriented. So that's corneoplasty. So when I look at all this, my least interventional surgery that gets me everything is myopic laser ablation. Here's the problem. Patient's hyperopic. I call this concept of mine taking you to Iceland before promising you Paris. All right, here we go. So the problem here is, now the patient forgets his anger because he's now become my partner. He's going, that's very interesting. Now, how will you make me myopic? I love the fact you can fix me. How will I be? I said, exactly my point. Now see how the mind works again. Remember, no barbaric surgery. The keratoconus cornea is always a deep chamber, right? The posterior capsule is open, correct? I just slip in another lens in the eye, piggyback, make him myopic. All his other issues are still there, right? Scar, high K, high keratometry, stigmatism, everything. But now I have made him myopic, which is what I wanted. Patient remembers a 3-minute surgery. We slipped in the lens, topical, same incision, we are done. So here's how it happens. We took him to Iceland first. Actually, I made his vision worse. But he has to have confidence in you, and you have to have confidence in yourself that you don't crash in Iceland. You still have to reach Paris, which is what you promised him. So there we go. We actually make his vision worse. But he's now ready, and then I go and do my laser technique on him, central straight to 2020. In fact, he's a pilot now, and his last vision record was 2015 vision. What does the patient remember? 2 4-minute surgeries, 3 months apart, done, topical. And I always like to show the patient, that's how they are. So my planning system is based on vision, then surgery, then technology. This is how I think, and this is where I spend my time, planning. That's the reason for 0 enhancement rate. Very important that you be proud of that concept, but there's a work that goes into it. Having done up till here, I'd like to stop now and take questions, and I will address your questions to Dr. Raylan. What's that?
Dr. Siddharth Raylan.
Excellent.
I'll have to stop your screen sharing, sir, for the time being.
Absolutely.
So we'll start with the questions for you, sir. These are the questions by the residents as well as the practicing doctors. Yeah. So the first thing they want to know is, what exactly is laser plastic? Is it a surface ablation? Is it different from surface ablation? What is the secret sauce that Dr. Gulani adds that makes it, that turns it from a surface ablation to laser plastic?
Very good. So there is no secret sauce other than the planning concept and your delivery of the surgery. So before I define laser plastic, my entire surgical series, lensoplastic, laser plastic, corneoplastic, that you all know of for 3 decades. Here's my concept, guys, if you can understand this. Fixing a broken nose is surgery. Are we clear? It's surgery. Fantastic. You fixed a broken nose. Whatever, you put a nail into the thing, I'm fine. It's surgery. Fixing the broken nose and making it look beautiful is plastic surgery. Are we okay?
Perfect.
Fixing that broken nose, making it look better than what it was before it broke, and compensating for the improper cheeks and ears without touching the cheeks and ears is plastic series, QUE. Are we clear where I'm going? When I operate on a patient, first of all of you know my statement, there is no such thing as routine. There is no such thing as common. Even my cat, hello, can you hear me?
Yes, sir, we can.
Even my cataract surgery, every case is unique, from planning to performance, right? So laser plastic is a surgery I've honed over 3 decades, where it's a surface technique with a large optical zone with cross cylinder of refraction, and you remove the least amount of tissue, patients have no pain, and you modulate your laser based on the refractive error. And yes, mitomycin in 100% of cases had 0 haze. In fact, I've shown you all repeated videos, not a single patient complains of pain. So I don't know what people are making this big scene about. And it works in 100% of cases. And you can fix all complications of corneal refractive surgery. We'll go into the technical details later. Today, my main thing is to push the attitude on everybody. So can I stop and ask, did everyone understand my definition of plastique, P-L-A-S-T-I-Q-U-E?
Yes, sir.
Wonderful. Next, please. And someone asked about training, and then there was one more question. Hello?
So what are the differences in the residency program in USA and in India? What is better where? And would you have been just as just as successful, or would it be more difficult for you to be recognized if you were still practicing in India than in the States?
So if you see how I teach, every question I share with you my principles. Number one, the difference is you. It's not about the place. I could have been, I'm blessed, whatever you call the success, to me, it's a passion. It could have happened here actually faster than in US because I had to repeat my residency, right? Now, in KM, where I trained at least, you could be, we had professors or phenomenal doctors, if you all know, at least I trained in Mumbai, every professor was mind-blowing in their knowledge and the way they would teach, everything. So that's inspiring. But what I used to do is I used to read journals more than textbook. In fact, you'll be surprised to know, I rarely read any textbooks on eye surgery. Maybe that's why I did not understand barriers. I never understood what cannot be done. I was like, why can't this be done? Why are people taking stitches? Why are they doing these stupid procedures on the iris and then stitching lenses and vitrectomies are considered? My experience of how many PCRs they've done. I'm like, that's nonsense. You should have a 0 posterior capsular breakage rate. So when I had that attitude, I would read the AJO and stuff in the professor section of the library, and I would always be there. So learning from different people, I learned what not to do. Always be nice to the patient. As your seniority goes up, don't get more cocky, be nice to your juniors, learn from everybody, and at the same time be not only available, but committed. At night, when most of people were enjoying after having finished their day of work as residents, my patients I used to take them from the ward. Our hospital ward was on the first story, and our slit lamp, the only slit lamp we had in our entire department, was in the bottom in the OPD area. And there we had a lock and key. It was really like a secret guarded place. So at night, I used to take my patients, hold their hands, and they would hold each other's hands. And these are, remember, old patients, poor thing, old patients, malnourished in many cases, so afraid to, have them fall. They would hold each other. And in the night, I would turn the lights on and I would walk them down and sit and watch each patient on the slit lamp. Remember, having a slit lamp at that time there was huge privilege because people were usually seen by the torches or lights, to see every detail of their cornea, lens, iris. And then when I used to do my surgery, I used to keep that all in mind. Remember, again, plastique took birth there, right? I used to not just do cataract, I used to worry about, okay, the iris or the subluxation or the trauma is here, but I will not do anything silly. I will do my surgery more delicately and arrange the lens with a capture. So that, I think, was very important involvement. So one was that, second, your patient's confidence in you. While I was a resident at KEM, I wrote one of the first books in the world, an ocular color Doppler of tumors in the eye. Now, how did I do that? My patients, again, their loyalty, they would come at night. These were discharged patients who had ocular things like tuberculomas and things like that. And at night, they would come for me by bus, by wherever, however they traveled, from far, far away. And I would take them to the radiology department, of which I had permission, close to midnight, open the place up and do, with the endovaginal probe, of course, cleaned up on their eyeball, and I would do the Doppler series on them. So at night, then I would type the paper in the neurosurgery department because they had the only typewriter and the only MS-DOS computer at that time, which I started for my entire college for KM Hospital. I took charge and got computers into the system for residents. So it's up to you. And all this while I was seeing 300 patients OPD, remember, right? Remember patients just charging at you and you're sitting there all day from morning to 2 o'clock seeing them. So with all the works of a resident, it is the drive that you have to excel. So to me, it made no difference. Now, when I fell in love with refractive surgery. Can you hear me?
We can hear you.
So I fell in love with refractive surgery, but at that time in 1994, refractive surgery wasn't a branch. It was cowboy surgery. It's like you can't operate on normal eyes, right? It wasn't normal. To me, wearing glasses is abnormal. It's like you have a crutch. So I was very passionate that this is the future. So when I started with that, I found nobody really who understood what I was saying. So then I looked abroad, and it was a pleasure, again, based on the credentials I had developed in KM. I was called to a fellowship. So when I did that refractive fellowship, I felt very empowered that these things are possible, seeing patient reactions. What I learned at that time, again, having done one of the first LASIK surgeries in the world and stuff, I even realized LASIK was wrong too. So I started laser plastic surgery. Even then, anything where you cut cannot be correct. And cutting as an our case, absolutely wrong because that's perpendicular. Again, the surgeons did nothing wrong. It's evolution, but I believe you should be right from the get-go for decades. You can't say, this was my experience, I did this wrong. No, that's wrong. You are a wrong thinker then. You shouldn't be a speaker. You shouldn't be a leader. You have to be right for throughout your life. Otherwise, it means you can't think. You're just changing and calling it evolution. Are you with me, guys? So even as
Dr. Ramesh Shah wants to ask a question, sir.
Yes. Let me just finish quick. So for doctors who ask me about the residency differences, I think there are none. It was in fact torture for me to go to residency in ophthalmology. I didn't know anyone before me who had done it, had no leeway, and did that because I had to. And I wanted to then acquire a work status, if you may, where I felt since the best work was happening in the US, why not, if you may, swim with the sharks? That's it. So I don't think residency makes a difference where you do it. How you take advantage of that and work hard and help your patients builds you up to become an amazing doctor. Yes, questions?
Sir, there are two questions. I request you to be brief on the subject only. Please elaborate about the intracameral steroid depot that you are using. Be specific only on that subject.
It is absolutely brain dead. That's not even a question. It's an intracameral steroid. It's the future, which is intracameral drugs. It's a microsphere in the eye. No big deal. You can read the product specifics. Not important question at all. Next question, please.
So this is with respect to the minimal residual stromal bed, because you have in some of your talks said that you even go as low as 140 microns with a surface ablation. So we've just got this question to get you to discuss more on that. Lovely. So we have a patient, let's say a 23-year-old female, -7 diopters, both eyes improving to 20/20, topography is normal, Pachy is somewhere around 440 microns. The ACD is good, which is around 3.2 mm. So you could put an ICL. So what would be your thinking? Would you do a LASIK? Would you do a surface ablation? Would you do an ICL? And what would bring you to that conclusion as to what surgery you have to do?
So doctor, this is a very important question, but I slam the surgeon who's asking me usually. I actually make a spectacle of them and thousands of audience when I speak. I won't do that today to you, but here's the important reason I want you to learn from me now forever. First of all, your question is, see how it's again backwards. So I'm forcing you all today. Does it help you? I'm forcing you all to think correctly. You see how your question has ended with LASIK, surface ablation, or ICL. What have I been teaching from the minute I started? Do not talk like a burger maker, right? Burger, taco, or hot dog. What should I give today? See how I think. This patient is 22 years old, has -7, is 6'6", topography normal, pachymetry 440, ACD 3.2. To me, this is a normal eye. All right. I don't even want to see the topography. It's not important anymore. This is a normal eye. Now, important question here is, what is the patient's profession? What is her inside lenticular status, which in this case, I'm assuming is normal, but I'd like to check in -7. And then in this case, I would go surface ablation. But given that there is very little astigmatism here, and the fact that she's 23, I would rather put in an ICL with a 3.2 millimeter and have my vision even beyond 20/20, because all of you know you gain a line more, correct? When you have an ICL at the nodal point of the eye. Does that help your answer?
Perfect, sir. Perfect.
Now, second part of this, very important. You said 140 and stuff, so I'll clear that confusion for you all, and I hope you are recording this so no one else ever asks these questions to each other. If you ever try this, Dr. Siddharth, right?
Yes, sir.
Try this for me, please, in any meeting, with any goddamn guy speaking. Just stand up there and go to the audience right now. What is the minimal residual bed? You'll see all of them are confused. All of them. And remember, I am the guy fixing everybody's boo-boos. Okay, everybody's mistakes come to me. My problem is, doctors are not understanding this. See, a 5 feet tall guy is not short. All right? And a 6 feet tall guy is not tall. They are relative. As long as they are normal. Now, 11 feet tall guy is a giant, and a 3 feet tall guy is a dwarf. That is abnormal. Are you with me? So the cornea has to be normal. That's the first parameter that the refractive surgeons have never been taught. They look at topographies. Topographies are reflections of the various modalities, having all lecturing on topography. That doesn't tell you normal, abnormal. First is refraction. Remember my statements? A refractive surgeon must know how to refract. If a refractive surgeon doesn't know what to do with a streak retinoscope, he's out. Cannot be allowed to touch a patient. If a LASIK surgeon cannot do lamellar surgery, out. Cannot do LASIK surgery. That's brain dead. So see, the teaching system is wrong. Second, I have not talked about 140. You see how relevance of this is very important. A normal cornea, you can take down to 400 microns. It's absolutely fine. It's absolutely fine. I've done this for 3 decades. In fact, if you know, I do laserplasty on keratoconus patients. But I can see the logic, the part that is not understood. Those are patients of higher astigmatism, very low myopia, in a patient over 40 who's mostly naturally cross-linked and has a 400 micron cornea. See how it makes sense? Now, people who understand the laser will understand astigmatism removes the least amount of tissue and yet gives you a nice oval 8 millimeter zone. So these patients are blown away with their 20/20 vision and night vision, and you just decrease their keratometry and they will not become a worse keratoconus. Are you getting me? Abnormal cornea. In a normal cornea, you can go down to 400, no big deal. I've gone to 370, no big deal. Point, cannot make it abnormal. Now, here's the other logic missing. In a patient over -7, it is already improper to do laser vision surgery on the cornea because optically that's an incorrect surgery. See how I think? Optically incorrect. Now, the brain dead answers you get from other doctors is, oh, I am experienced, I can do LASIK in -12, or I do SMILE in -14. That's stupid. You just exposed your stupidity to me, because if you do more than 8 diopters on the cornea, it means you don't understand optics. Are you getting my way of thinking? It's not about what you can and cannot do. It's nonsense. You did more than 8 diopters on the cornea. You just exposed to me that you don't understand optics. Yes, your patient's happy because they came from blindness to good. They're blown away, but you did a disservice to them. You need to put a phakic implant of some kind in that eye. Later, I'll talk about how you can even combine and stuff, but that's the basics. So you see, the thickness is a relevant issue. More important, is it a normal cornea or abnormal cornea? Abnormal cornea, only do laser if it's astigmatism more than anything, optical zone, and residual cornea. Rest doesn't matter. And then the age factor, just because, as you'll know, more than 40 people are naturally cross-linked now at that point, unless you need to cross-link in the future. Does that help you?
Perfect.
Doctor? Are we clear about this thickness concept, so no one should ask about this again, right? Great. Next.
Your choice for when do you go for an ICL and when do you go for an RLE. So let's say we have a theoretical case where we have a 40-year-old male who's improving to 6.6 with +3 diopters, ACD is 3.0. Would you prefer an ICL or an RLE in this patient? And what would be your parameters of choosing one over the other?
Doctor, you keep slipping back to kindergarten. I keep pulling you back to college.
We have residents over here, sir, too. They have.
Oh, residents are just following what they've been taught. That's a reflection on the bad teachers. Are you getting me, guys? Residents are just a reflection on that teacher. The fact that I want to break this backbone of wrong thinking, ICL, RLE, once again, you're talking burger, hot dog, right? You're already shortened your wavelength and the patient is getting just 2 options. Wrong. See how I would think. 40-year-old male, best corrected 6.6 plus 3D. You agree with me, Dr. Siddharth? There is no abnormality here. Lovely. Now, again, profession. Most likely it's a pre-presbyopic or presbyopic, so he's already frustrated with +3 and maybe a +1 up front, so it's about +4. Next, you would do a cycloplegic refraction, see if this guy's actually a +5. Most likely is one of the eyes amblyopic. You'll just check for these things, very important to me. Now, given that he's a 3 millimeter and he has all these issues, here's the biggest thing that's missing from this resident fellow. What is that, Dr. Siddharth? And I don't want your topography, okay? I have everything in the world, but I don't want to see your topography. Give me one thing that's missing here. A very small thing available in any
status.
Pardon me?
His near vision status, whether his near vision is
No, I already presumed, right? He's pre-presbyopic. Next. What is that small thing missing that is available in every office? No big deal.
The pachymetries.
Do I care for pachymetry? Siddharth?
Yes, sir.
Do I care for the pachymetry here?
No, you don't, sir.
Why?
Because it's not relative.
No. Again, you're missing the teaching. This is hyperopic treatment. Are you working in the center or periphery?
On the periphery.
Exactly. How does the center matter to you anymore? Guys, you got to understand when I teach. It's not just teaching you one fish, I told you, right? The mind should open up. So come on, tell me, what's that one thing missing which will make me decide where I'm going here? Rest being exactly what we analyze. Is that helping you all, guys?
The lens is clear or not?
We said that. It's clear. 40-year-old. Next. Come on. Who's the resident? Come on, guys. If you haven't used this machine in your OPD, you're coming out as a very poor surgeon.
The K-metries?
Yes, doctor. Exactly right. Wonderful. So why is that important here, Siddharth?
You don't want to increase the case over a certain level, sir. You probably
Again, remember, I don't have levels. I don't have any box I live in. But yes, it's all relative. Remember, relative intelligence. So yes, if you tell me the keratometry here is already at 45 or 46, I don't want to distort the cornea. Are you with me? Can I do it? Yes, I've done +7 on patient. But see, the rationale is what I'm trying to push on y'all. It's not that I went in with 2 surgeries. I came up with the desire for, I want to steepen this cornea and give him this level. So if this keratometry is in the 42s and 43, Siddharth, I would go surface, laser plastic surgery, whatever you call it. You can do your PRK, whatever. The beauty of that, this patient will also get reading vision. You agree?
Because the Q values will shift. The Q values will shift, so you get some reading vision as well.
Forget your Q values, man. You're correcting +3. Is that correct?
Yes.
You're already seeing better reading? Yes?
Yeah.
Second, you're creating a multifocal cornea, right? You're creating the peripheral hump. So the cornea is now going to read better. How simple is it what I'm saying, guys? How confusing is what you should explain to me? So the Q values are a goddamn molehill on a mountain of hyperopia.
So, but what about regression following surface ablation after hyperopic correction? Because hyperopic corrections with surface ablations tend to regress over time.
They do not. They do not, if done properly. And I found the biggest reason patients keep, and again, doctor, I'm assuming you're an experienced refractive surgeon, whichever nutcase gave you all this statement was actually exposing their inability to perform. You see me? Someone taught you this, you accepted that fear, and now someone learning from you will also accept that fear. It's wrong. Here's the biggest thing I've seen in surgeons who come to me with this problem. That's not in my hyperopic laser surfaces fail. I ask them one question: what's your ablation zone? What's your ablation zone, doctor?
With the bigger the ablation zone and the bigger the transition zone, the more stable is the hyperopic refraction.
You said it. I know that. My point is, what is your ablation zone in hyperopia?
I usually keep it at around 6.5 and a transition zone somewhere around 9.5, or at least a 3 mm transition zone.
Good. You should be at 9 millimeters of the optical ablation. There's your answer. Now, that is one among 4 factors that I've designed for why doctors are getting these regressions. But please, sir, if you all want to improve today, cannot accept that statement anymore. Are you with me, guys? Have I broken that shackle for you forever?
Yes.
Hyperopic laser doesn't work in the hands of people who cannot perform. How clear is that answer?
Okay.
A tennis racket doesn't work in many people's hands. And yes, Federer can shoot it all the time, right? We need to become those kind of players, guys. I want no limitations on it all. So now, you understood my point here. In this normal eye, if the keratometry was 42, 43, Siddharth, I would go with the laser, normalize the cornea to 45, actually give him good night vision, good reading, correct him forever. And when you go for cataract, it's going to be a beautifully easy case, which he will have, right, in about 15 years. And if that is high, let's say 46 at this point, I would go intraocular in this case, because a safe surgery, you may also deepen the chamber because this guy might be narrow angle, correct? And you're done forever. He'll be blown away. How simple is that answer?
Perfect, sir.
Not to go the way you guys are going, ICL already. See how if you think forward, you can actually perform. There is no barrier. You're not stuck with anything. Patient sees that brilliance in you, that, oh my God, I can have this kind of thing. Yes, you can. And here's the reason. So explain to the patient, make them your partner. You cannot just talk to yourself. Oh, I'm going to do this. Wrong. The patient should understand why, and then they become your partner. Okay, next question.
Okay, this is with respect to cross-linking and surface ablation. Okay. So there are many studies and people are confused. Should you cross-link first and then do a surface ablation, or should a surface ablation follow cross-link? What do you follow and why do you think it is better that way?
So everything that I will teach you will become your dogma from now on. It should become a rule because it's logic-based. Everything else that anyone else has taught is based on the last free wine they got last night. So here's the answer. Think about this for a minute now, Siddharth. How many participants are on right now? 69?
I'm sharing the screen so I wouldn't know.
69.
69. I could show you now my slide first. I'll go there for a second. Can I?
Yes, sir.
Just give me a second. I'll stop sharing.
Sure.
Yes, sir. You can share now.
Let me go straight to that question for you because you'll see it better in the graphic that I have for you. All right, can you see this, please, everybody?
Yes.
Good. So imagine this. Keratoconus is nothing more than a bent spine. Is that okay?
Perfect, sir.
Yes, sir.
It's not broken, it's bent. Now you can waste your energy going into PMD, keratoconus, call it whatever you want. What I don't want you to do is call it all those names and go to sleep. Do something. So you see the bent spine here. Now here's the most stupid thing you can ever do in your life. Cross-link these patients immediately. Please pardon me. I'm being very tough on you all because I love you guys. I'm calling these things stupid because I want you to go home and go, oh my God, I'll never do this again. You're taking a bent spine, right? Let's call this patient Mrs. Smith's son, all right? So Mrs. Smith, your son has a bent spine. I'm an amazingly advanced surgeon. I just went to US or Europe or whatever. There's this new technology about cross-linking. I'm going to stop his spine from bending anymore. Sound very smart, right? Here's what the mother's asking you. Doctor, I appreciate that. You're going to stop him from bending anymore. But what about straightening the spine? Have I answered your question?
Perfect, sir. Perfect. It's done.
Gulani keratoscoliosis concept. I had to bring it down to kindergarten language to make my colleagues understand and the industry understand. Cross-linking is very important, guys. I've been doing it for now over 25 years. My point, it is an amazing technology that we have, and I'll show you later how you can do all kinds of corneas. Point is, fix the shape first. Imagine if this was your only son or daughter, and someone took them and just cross-linked them. Now, how does your son or daughter come home? Hey, doc, that advanced doctor I had, that guy, he cross-linked. Well, okay, but you're still goddamn blind, right? Yeah. Yes. I don't see. He said, I'll never see. And he said, go and get contact lenses. Who was this? He's some big surgeon. He's very smart, he said. How does that sound, guys, for a minute? Can you absorb that, what I just said? If I show you videos, I have patients crying on the telephone to me from all over the world, lots from India, crying, begging. They've spent all their money, the doctor did crossing, and then told them nothing can be done. How is that fair? Am I answering your question properly? So now if you see this, rather if you straighten the spine, how do we do that? I'll show you my keratoconus treatments. Straighten the spine, whether it's the laser surgery I discussed, whether it's the intacts, lamellar techniques, whatever. Now cross-link, if needed. Permanize the procedure. How's that?
Perfect, sir.
The only time I will let you cross-link in a moving keratoconus is a moving keratoconus, right? A young patient, let's say less than 22 years old, who's moving and you want to stop it. All right. Even there, I'm getting aggressive with doctors that if they're over 18, 19, fix it with the laser because they're basically stigmatism with some myopia, which is easily correctable, and the Ks come down and they're done forever. I'll show you some cases. But are you getting my point, guys? So do not cross-link a keratoconus. I'm talking, let's say, patient over 25 years of age. Do not cross-link unless you fix the cornea. Otherwise, you are actually committing a crime. You are leaving them permanently disabled. Think people walking around you with a bent spine and they say, my doctor was great. He made sure I didn't bend anymore. It's like a stupid goal, right? You want vision. And these patients are blown away with their vision, okay? As you can see, these are firefighters all in one day, which were fixed straight to 2020. So very important. I'll go back quickly into this while you get the next question ready. Next question.
Next question. Just get it. Oh, we've just gone back a few slides. I'll just
sure. Is this helping you guys? This pattern, understanding everything?
Yes, sir. So yeah, this is with respect to one of the cases which you have already presented, sir, but this is just to get everybody to understand how you think. What are the limits of astigmatism correction with laser vision correction? So let's say we have a hypothetical 22-year-old female with a hyperopia of 6 diopter sphere with the rule astigmatism of 7 diopters at 90 degrees. Patient is having a BCV, a reasonable BCV of around 6/12. ACD is low, so ICLs are out. A reasonably good pachymetry and topographies are normal. Would you operate her if she wants a laser vision correction? What would be your laser parameters? And once you finish that, sir, I would like to have your views on this new treatment which is coming up, that is intrastromal lenticular rotation. It is with the Visumax, where you do not remove the lenticule, you just rotate, you do half the cylindrical correction and you rotate it by 90 degrees. So basically you're converting, let's say in this case, you'll be converting 7 diopter cylinders into 3.5 diopter spheres. So your views on it, and because the people in Germany are doing it, there are a few articles ex vivo which have been published, but not too much is known about it. So we'd like to know your views about it, this as well.
Certainly. So again, first let me pull you out again from the gutters of limits and can and cannot be done? The answer is yes. This is your only son and daughter, has to be corrected. How's that mindset, guys? Are you with me? You know, I will not teach y'all if y'all don't understand mindset. If you constantly keep making excuses that you don't have this and that, and hence you cannot do this, or there's some goddamn bullet coming from the planet Venus for you, there is no such thing, guys. Refractive surgery is over 100 years old. All right. Your concepts are what are unique, and that doesn't change. So here's how we go. 22-year-old, first of all, this patient cannot exist. This cannot be true. 22-year-old with +6 and +7 and 90 is impossible. That's not, there's no real case like this. But let's go even in this scenario. 22-year-old female +6 hyperopia, +7, so she's surely amblyopic. Everybody agrees straight out. Second, this is absolutely a non-ophthalmic eye or some silly stuff going on, and +7 at 90. So like I said, this cannot exist. The pachymetry doesn't matter. What is missing, doctor, again for me here?
The key value, sir.
Wonderful. So that's missing. So whoever did this, I hope they learn at least that little part today. Keratometry will help me a lot. Now, the problem we have is a 22-year-old patient whose lens is accommodating and helping her read. But the reading is now off balance because a +6 and +7 is way off track for her vision, correct? What I would do here is, again, K's are missing. That's very vital for me to make a decision. But you do not want in this case to go in the eye because it's a very young patient and the lens is not at fault and it's accommodating, correct? That would be my first thing. ICL of any kind cannot go in because the ACD is very shallow over here, all right? 2. 3, in this case, I would absolutely go on the cornea and see how the K's become important here and do the treatment of the +6 -7. Again, I work in the -7 because that's the intelligent optical way of working. And because that's at 180, this is a normal cornea. And by doing the -7, I will actually decrease the keratometry increase I'm going to cause by hyperopia. So this case, again, we made sense out of it. We will do laser surgery on the cornea. Everybody with me?
Perfect, sir.
But more important, did you understand how I came to my decision? I did not go in with just 2 little bullets going, what do I do today? You see the thought process here. That's what we'll do. And here's one more thing, guys, for everybody listening to me. There is no such nonsense as I do it this way. What would you do, doctor? And have a conference on that. That is bullshit. Don't pardon my language, guys. I'm going to be very tough on you. Got it? No nonsense like I would have done this. I would have done this. You're like, go, both of you go home. There's only one thing to do for a patient, the right thing. Should I repeat my statement? Only one thing every patient deserves, the right thing. If you can't do it, get off the goddamn highway. Just move out. Don't be an ophthalmologist. If you cannot focus on what's right for the patient, you will never perform. And please get rid of these nonsense conferences. I would have done this. I do this. I do this. See how we came. Are you guys understanding how we came to this conclusion? And see now, I'm not giving you or the patient any options because I have responsibly come down to exactly what we should do and why. Are you getting it?
Perfect, sir.
Yes, guys? Excellent. And then this treatment, Visimax. Again, guys, to me, anything that is not accurate doesn't make sense to me. You're rotating a lenticule. It's a stromal lenticule. Got it? Hello? Who's there?
Sure. It's done, sir.
Okay. Are we okay? Hello?
Are we fine, sir?
Are we okay?
Perfect, sir.
Can you hear me? Lovely. So first thing I want you to understand is how we came to a decision. Even in this non-existent, completely fabricated case, we came intelligently to a decision and we're not giving options. We're not discussing what Dr. Raylan would do, what Dr. Kenya would do, what Dr. Ragini would do, what Dr. Gulani would do. Patient deserves that one treatment. That is right for that. All right. Second, any procedure that takes lenticules and tissues and plays with astigmatism can never be as accurate as the laser on the cornea. Just write this down, please, from me. So I don't want you all being fooled into this nonsensical, I call these entertaining sideways that takes you away from your target. Nothing wrong with this direction, but that is not as accurate as laser on the cornea. Similarly, it cannot be as accurate as the toric lens in the eye, provided we know how to do it. But you see my answer again? It doesn't matter to me. I like the fact that people are thinking of this. In fact, that's how I actually break down my refraction for the last 30 years. This company is finally getting it and they're moving in the direction, but rotating a lenticle cannot be as accurate as laser on the cornea with the corneal astigmatism. Next question.
So your views on corneal biomechanics, and do you screen them routinely for your pre-LASIK evaluations?
You answer that for me now.
Sir, I don't, but there are doctors who do.
Exactly. So here's my point. If clinically you cannot determine the cornea as normal, you have no right to be a surgeon. Now let me expand on that, please. There are various technologies. There is the corneal elastomer, you know, the measurements that you have, the corvus, etc., that measure all that stuff, right? Great. It actually gives you too much data that puts you in a scenario of confusion more than anything else. And in fact, I just recently gave a talk on this and I cleared off 12 out of the 12 questions that I got were all based on the same thing, which tells me there's too much confusion. And my answer, as you know, was always logical. And finally, the guys, the lights go on. They go, oh my God, yes, that makes sense. Exactly. If your astigmatism is with the rule, your cornea is more than 500, all right? And the patient is refracted to better than 20/20. I don't care about the corneal mechanics. Because if the corneal mechanics were abnormal, wouldn't there be a factor of abnormality that would prevent 20/20, that would prevent or have the astigmatism against the rule, and that itself would have its fluctuations and limited values? That's my clinical assessment. So yes, if you have the technologies, you may use it. I do not think it has much value in normal cases, none at all.
Sir, I'm stuck here. I have a blank screen. I'm not sure if everybody's having the same technical problem. Dr. Vaishal?
Yeah, the screen
here.
Yeah, we can see your screen.
For some reason, it's totally blank here, sir. I'm stuck with, I mean, I have
Can I ask a question?
Yeah, Sachin, go ahead, please.
Yeah, after Dr. Gulani's inspirational talk, I mean, he's doing a lot of surface ablation. That's what we found. And he said that after that, the patient does not have any pain or any discomfort. But here, when we are doing surface ablations, patients, even after the bandage contact lens in place, they have a lot of lid edema, photophobia for at least a couple of days till the epithelium heals completely. So can you share with us what his protocol is post surface ablation so that we also can get similar kind of results?
So this question also I get a lot, doctor. It just tells me there's something you guys are doing wrong, but let's go through what I do. It's very simple. And I've shown these videos constantly. If you go to my YouTube, there are thousands of videos and I do this just for y'all. In fact, I have patients talking on day 1 during surgery. You saw them under the laser, day 1, day 5, 1 month, 1 year, 10 years post-op. I still keep on questionnaires with them because thank God we haven't seen this. Now, few things that I'm going to ask you quickly, doc. What do you use to remove the epithelium in your PRK, let's call it?
Yeah, we use either we use the alcohol and the blade, or we do a trans PRK.
So both of them are wrong. Never do a trans PRK. It's a brain dead surgery. It's a marketing hype that I see a lot of complications of. Don't do it. Never use alcohol, the cornea or the surgeon. Both of you stay away from it. And only remove the corneal epithelium with a simple spatula. Okay. I have sent this in for publication 6 times. 6 times the Academy has sent it back saying it's too futuristic. I'm like, that is brain dead. So you want people to go through evolution before they learn my technique. So mitomycin must be used in 100% of cases. Doesn't matter how thick or thin you're going into the cornea. Remove the mechanical epithelium mechanically. This will also teach you what I'll teach you about scars in my next slides. I can look at somebody removing the epithelium with a spatula and tell you how good the surgeon is. Let me stop right there. I can tell you how good a surgeon is by seeing them remove the epithelium on the cornea. It tells me about their confidence, the elegance, and the empathy for the patient. All 3 things I get just watching that part. Nothing else I want. So do that, doctor, and you'll see things change. My protocol post-op is very simple. Steroid drops, whatever you have, go for 4, 3, 2, 1 over a month. Antibiotics and the NSAID drops go for a week to 2 weeks, once a day. Antibiotics is twice a day. That's it. Nothing else for anybody. All right.
So you do not continue steroids for longer time, more than a month, even post PRK.
I just answered that question, didn't I? I just answered that question. Never.
Okay, thank you.
And please pardon me, I'm getting tough on all these questions because these are redundant questions taught by poor teachers who are poor surgeons. So I'm just getting very firm here. Cannot have these doctors who fail teach you wrong things and then you are scared and you continue the wrong thing. Alcohol and PRK or anywhere in the cornea, unacceptable. Unacceptable.
Sir, I
So
differ on this.
we divide it directly
Yes.
without any. Okay. Thank you.
Yes. I will show you some videos later. I will show you some videos, or you can go on YouTube because of time. But
Dr. Nitin Balkrishnan has a case to discuss.
Okay.
Could he discuss?
Go ahead, please.
Dr. Vaishnav.
Yeah.
Hello.
Yeah.
See, I would differ with Dr. Gulani about the surface direct ablation without alcohol. I've been doing it for last 15 years. And we are doing with the alcohol and we are very happy with it. We don't see so much of pain at all. I think alcohol and other methods are also equally very good. It's not something which is wrong. I don't think this message is very clear to all of us that do only. I don't think it's the correct sentence.
Doctor, doing something you do is okay for your practice. I'm telling you what works and what is correct and what should be done, because there's a next level to this surgery. Doctor, do not interfere when I'm talking. When you do surgery with your hand is when you will learn how to work on irregular corneas.
You are giving the wrong messages everywhere. I'm talking of that kind. You might do what you like, but the other thing which is not right.
My next slide will show you where I want you guys to be.
I will give you
scars.
the example and I will give you the data of 13,000 patients.
It's okay. I appreciate that. Here's my point though, doctor.
I accept that alcohol is equally good. Even the PTK is equally good. And something which is, we all don't do direct. And I
Doctor, what are your visions of PTK patients?
All of us.
Doctor, what's the vision of your PTK patients?
Most of them are doing extremely well to the extent of 6/4 vision.
Without glasses.
Huh?
Without glasses, right?
What are you saying?
Without glasses.
I'm talking of, we put the lenses for 4 or 5 days. All of us are putting the lenses.
No. Doctor, you're doing PTK. Are your patients seeing 20/20?
I'm not doing PTK. I'm doing alcohol for last 30. I think all of us from the audience, please explain to your experience with PTK and alcohol. All of them are doing well. Not so much of pain. Practically, alcohol with Rexis type of ablation, removal of epithelium gives a wonderful results.
Again, doctor, it is not about alcohol.
In your experience, fine. But what you're doing is not wrong.
Doctor, it's not about wrong. I want you to see the next level where I'm taking you to irregular cornea. Second, you said you do PTK.
So many things which is there in irregular, but alcohol actually it's also working for everything well.
Let me show you how to take it to the next level. Alcohol works.
I don't have a slides to show me also that we are also doing all of us very well. What I'm trying to tell you is that it's getting a wrong message everywhere.
It is not wrong. Listen to what I'm saying carefully. First of all, doctor, you said you do PTK. Is that correct?
I do most of the time alcohol. My friends, all of them do PTK and they all talk nice.
Doesn't matter. Alcohol doesn't matter to me. You're actually answering the question of the guy about the pain. I'm explaining to you where I want it to be. So here's my question.
Even
in your PTK cases, are your patients seeing 20/20 without glasses? That's my question.
20/20 is something which is there last 10 years back. What we are talking
in PTK cases,
I'm taking off alcohol based. Even patients up to 6/4.
Doctor, here's my question to you.
Dr. Gulani, I think there is a confusion. What Dr. Ramesh Shah means by PTK is I think Ramesh, RC, correct me if I'm wrong. I think you mean trans PRK.
No,
epithelial removal by PTK. That's what you mean.
I always mean removal of alcohol, removal of epithelium with alcohol.
Doctor,
that is my personal experience.
Doctor, that's okay. It's okay. It is not important. Here's my point though. You do PTK, you said. Is that correct? PTK. It doesn't matter with or without alcohol. Do you do PTK?
No, I don't. I do PTK. Yes, I do PTK.
Okay, here's my question, doctor. That's what I'm trying to get across here. Are your patients seeing 20/20 with PTK?
No, we are saying beyond 20/20. I'm not talking of only 20. We go for 2 steps ahead of it.
So what is the PTK you're doing for them? Why are you doing PTK? For what's the case indication?
The irregularities which is there. We have always been doing irregularity corrections wherever it is, whether it's a normal cornea or abnormal.
So let me show you the corneas now. I love the fact that you do these cases because it's a very important part of what I'd love to show y'all is irregular corneas. So Dr. Balakrishnan, if you're done with your question, I want to go into this because that's a very important part. If Dr. Shah is doing it, I want everybody to be inspired that it can be done. So go ahead. Your question.
I had a case. Can I just show it to you? Can I share my screen?
Yeah, sure.
I think I'll have my screen share is disabled. Can someone?
1 second. 1 second. 1 second. Yeah. Now?
1 second.
Yeah. Fine.
Is it visible?
Yeah, very much.
Okay, so this is a case of a 29-year-old female patient who's recently married, who came to us for a refractive surgery. She's not started a family yet. Her refraction in the right eye was minus 275 sphere with a 1 diopter cylinder, and the left was 225 with a 175 cylinder. This is, let me just change the.
Okay, we're running out of time, guys, a little faster.
Okay, this is her the pentacam map in the right eye. And this is her pentacam map in the left eye.
Okay, next.
Okay, a pachymetry of about 490. 490. Okay, so my question here would be that would you do a refractive surgery for this patient right away? A, would you ask her to finish her childbearing and then come back for a refractive surgery? B, because her refraction is not very high. And C, in case you're planning to do a refractive surgery right away, would you do a surface ablation? Would you do a surface ablation with the cross-linking at the same time? Or would you still go ahead and do a LASIK?
So, doctor, let me understand your question. Why are you asking about right away? Is there a question for that?
The patient obviously would be going into a childbearing. Her BAD-D maps are not so good. So it's theoretically known that probably she may develop ectasia following her childbearing. So that's the reason why I asked right away.
Great, great. When is she expecting the childbearing? Is that within 6 months?
She is not planned yet, but they want to start a family soon.
Okay. Again, see my logic, doc. Compared to the previous discussion we had, it's not about alcohol, not alcohol, but the logic, how we want to go. Here, the logic is, why did I say the penacams or the topography is not important? Now, if somebody with a low IQ is listening, they might just take this as a statement. I don't like topography. That's wrong. Your astigmatism is with the rule. Okay. Myopia was -2 something. It's a young girl, but she's over 20. Now, my first question comes back to what I was talking to that doctor who was here, who was moderating, right? The fact that she wants vision correction is a birthright. All right. So yes, we must do something. Now, unless she's planning pregnancy in 6 months, then you would say, okay, let's wait, get through the nursing also, then we'll do it. All right. The fact that we need to do something is a yes, number one. Two, given that her refraction is stable, she's over 20 and the astigmatism is with the rule. Pachymetry you said was over 450. I thought you said 490 something.
490.
Correct. So my answer is absolutely proceed with laser ablation with mitomycin, and that's what you would do. You see that? The
would you cross-link at the same time?
Sorry?
Would you cross-link at the same time considering the...
Considering what, sorry?
So would you cross-link the... Would you cross-link it or not?
Why would I cross-link? Why would I cross-link?
Considering that her pachymetry is about 490 and that she would probably land up with a childbearing within the next year or two, and the chances of ectasia theoretically are known to be higher during childbearing at that in this particular age group. So would you like to cross-link at this age, at this time?
Again, doctor, see how it comes down to logic again? Is there any harm in you cross-linking? The answer is no, right? Is there any harm? The screen's gone black. Is there any harm in you cross-linking the patient? The answer is no. Can we have a debate about should we or should we not cross-link? Not worthy of discussion. Here's my more important question. This is a normal cornea in a normal patient with all normal statistics. I would only cross-link if needed. Here's what I would do in this practical case scenario. First of all, I'm not worried about the 490 because it's not an abnormal cornea. I would just monitor her every 6 months after surgery. Okay. If I see any movement, even slight happening, I will cross-link. If not, I would just watch her because I expect nothing to go wrong here. It's a normal cornea, doctor. Do you agree? So again, we're going back to the very important point that I said to the moderator before is let's avoid doing things just because someone has said these things and made it a protocol. Let's use logic. By you cross-linking, you're causing no damage to the patient, but is it really needed?
So what protocol do you follow for cross-linking?
Vaishal. Excuse me.
Yeah.
Vaishal. It'll just come to one fine point. I think it is a sticking point with all of us. I'll ask this to Dr. Gulani.
Yeah.
His talks are very inspirational, and the logic process is extremely, inspirational. But the only one sticking point I think we feel here is we all in India are shackled by the lines that are drawn by certain literature about maybe the pentacam D values, or maybe the thinnest which you can go with refractive surgery. So when he like Dr. Gulani is planning a surgery back in the US, do these guidelines like the AO guidelines or whatever have any medico-legal overbearing? Because that I think shackles everybody back in India here, at least that's what I perceive. Dr. Vaishal and Dr. Nitin can correct me if I'm wrong, because even in his question, there was an overtone about, everywhere about ectasia. And like Dr. Gulani rightly pointed out, logically, you would correct. And then if there is an ectasia, would cross-link. But the sticking point in the mind is, what if there is an ectasia? Would the patient come back and sue us? That kind of a mindset, I think, is shackling us. And what Dr. Gulani has to advise on this? How do we approach this kind of a shackle on the mindset?
Surely, Dr. Sachin. Very important question. Now, do understand, I practice in the US, which is absolutely legally, the status of lawsuits in the US, correct? Compared to India.
Yes, absolutely.
And don't forget, again, every patient I see is not ordinary. They're very intelligent, very demanding. So I appreciate that thought. And of course, that's always in my mind, right? That's why what I'm teaching you all today, I want you to make sure you'll understand the logic. Don't take it as this is the box again. Logic, I want to free you up. So see how I think. Yes, there are guidelines. Yes, there are protocols by industry, but you are the doctor with the logic. All right. And as long as you have integrity, if you're somebody who's just advertising, schmoozing, doing mediocre work, you're already in a difficult scenario. But if you're confident in your work, you really care, and you're planning like this, I cannot guarantee, but I can promise you, you'll be safe all the time because the patient gets it. You're working for them. Now imagine, doctor, I see here the name Dr. Nitin. You asked that question, right? Now, if you explain to the patient this concept, you see how they understand it. They get it. Oh, yes, I'm concerned because literature says you might go into ectasia from pregnancy, you're less than 500, etc. But see the logic here. You don't need cross-linking. I'm very confident that we can do this technique for you and make you see, because you do want to see and you don't know when you're getting pregnant. You get me? Involve the patient in the planning and they understand, just like you're understanding as I'm talking to you. Only reason I'm getting very tough is I get these questions from you all so many times that I'm spending this very precious time of mine for you and hammering it in that is logic. So yes, you have to keep legal. Yes, you have to be very empathetic to the patient, but the logic cannot move. You cannot do something just because and then sit back. Your results are very important. Very important. So again, you see, I'm not going into those details, which laser you use, what's your protocol, what kind of stuff, like we said, a very experienced doctor was there recently talking about the irregular corneas with alcohol. I'm fine. As long as there are results, continue. But where I want you to be is next level. Because once you know how to remove the manual epithelium, I'll show you how you can deal with scars. I have not done a PKP for 25 years. With the world's largest complex corneal referral practice. I want you to do that. I'm here for that. Anybody can do a transplant. Transplant should be a surgery for a junior resident. Cut a cornea, put a cornea, 16 stitches. The easiest thing you can ever do. Why are the people thinking it's great surgery? No corneal transplant patient ever sees 20/20 without glasses, remember. Are you with me, guys? Yes?
Yeah.
So you see the scars and irregulars should be corrected. So in this case, doctor who asked the question, yes, you must be concerned about the medical legal, but don't take that into wrong treatment. Cannot do that. If something is not needed, it's not needed. Explain to patient, get an informed consent, and be very clear with that discussion. Right?
Okay, thank you, sir.
So just a question, sir. Which cross-linking protocol do you follow? If you had to, do you vary the protocol according to the patient requirement?
Yes, I do. Always. Always. And my protocol is basically based on what am I trying to do? Like I said to you, that's a whole different talk where I do it in RK cornea, certain cases, ectasia corneas, post-intacts, or just simple keratoconus. All of those varies based on various parameters that I can share with you all later. Absolutely has to vary. Think about it again, Dr. Kenya, is that correct?
Yeah.
Think about it, doctor, again. What I explained to you with the spine, right? Keratoscoliosis. Can you put the same amount of cement on everybody?
No.
Can I just stop this meeting for a second so you all can all look in the mirror for a second, look at yourself and go, why then am I doing the same protocol for everybody? You see how, again, the logic comes in, Dr. Raylan?
Yeah.
Are you getting it, guys, what I'm trying to force into you today?
Absolutely.
Y'all are wonderful surgeons. Y'all are the most experienced in the world. But the logic, every day I get 60 to 100 emails from all over the world, quite a few from India. Questions are all the same. Can I, Dr. Gulani, do LASIK in this? Can I do this and this? I'm like, I already taught this. So see the logic. If you say this is correct, if you get the same amount of cement on every bone, how does that make sense? Have I answered your question?
Yeah, perfectly, sir.
Next. Go ahead, next question.
Should I?
Yeah.
Dr. Ramesh has a question.
Yes, go ahead.
Sir, you have to unmute. Dr. Ramesh, you have to unmute. We can't hear you. Yes, sir.
The one which is an hexagonal keratotomy, which you did wonderful work. And the same patients, suppose you have done a pupil or the other patients where the pupil is quite irregular and other things, not with the corneal opacity. Will the pseudophakic, if at all there, the one patient which you have shown.
Okay.
I have one more suggestion that pupilloplasty to make the pupil very small would have given probably the similar results. What is your thought on that?
Again, Dr. Shah, is that correct? Dr. Shah, again, excellent. The very fact that you're thinking in that direction makes me so happy because it means you're not scared to tackle the scenario. Are we clear? That was my first point when we started. Second, now here's my logic again. See, why will I do pupilloplasty? It's a wonderful surgery. Actually, one of our very dear friends, Amar Agarwal, has invented this concept, is single pass pro. My point again, in these cases, I want every resident fellow to first do what I did. Here's why. I want them to have the confidence that they can correct it. Pupilloplasty, I would do in a case which, God forbid, if I failed in her case, I would do pupilloplasty. But by succeeding, I have proved to myself that I can tackle it. You see, pupilloplasty, if I had to do in a case, Dr. Shah, Dr. Ramesh Shah, is that correct? Dr. Shah, I'm already giving up before I start. Are you with me? I'm already giving up. I'm going, okay, she has so many fractures, I'm going to put the whole body in a cast. Now that means I'm not even trying. Yes, pupilloplasty will give you great vision because it's pinhole vision, but you've distorted so much. And to me, more important, because all of you, I love you guys, is you have already given up. So I would reserve, this is again my logic, I would reserve the pupilloplasty in a case where I just couldn't perform. God forbid, it hasn't happened. Let's say I've even got a fall, like I said, 34 irregular stigmatism. If I completely failed, I would do a pupilloplasty. Does that make sense?
Yeah. One more question, one more suggestion. In one of the cases where a lot of RK marks were there and you have a hyperopia, which you corrected very well with the help of laminar keratoplasty. So wonderful work. Can we do whatever number of RK incisions are there where you can take the sutures and tighten it? I did 3 cases of that. And from my +7 diopters, +8 and +9 diopters, we brought down the hyperopic corrections to this is very simple procedure with all of us.
Right. Again, doctor, can you hear me?
Yeah.
Again, can you hear me, doctor?
Yeah, very much, sir.
So I love every question you're asking. I love it because it shows you are tackling these cases that most doctors do not. But here is again my logic. See my logic, which I'm forcing through. I love the fact that you got your results. Here is my objection. It's an inaccurate technique. You used an inaccurate technique based on your experience and got a good enough result. Had you used the laser plastique on this RK cornea, we'd have an accurate technique to 20/20 vision. Are you with me? So nothing wrong you have done, doc, but I don't want an inaccurate technique because I want our drive to be perfection. Like I give the same example. All the bones in your legs are broken, Dr. Kenya, but when I approach you, I don't think, thank God you're alive. I go, how can I make you run in the Olympics? Are you guys with me?
Okay. Yeah.
Can you please repeat this for me in your own mind? When you approach an accident victim whose all bones are broken, how one doctor approaches and says, thank God you're at least alive. The other guy goes, yeah, you'll walk, here's a cane. They're not wrong. I want your approach to be, how do I make you run in the Olympics? That's the mindset when you meet that guy. If you can keep that mindset, I guarantee your surgery will come up to that level. And Dr. Shah has described, I wish other doctors were also doing these complex cases, but the more you do them, you'll realize they are possible. You see, the surgeons that many of these patients who come to me have seen are all brilliant. They're not ordinary, they're brilliant, but they all thought surgery. That's a mistake. They all thought, how do we stitch this? How do we do this? How do we remove the vitreous? And I'm teaching vision. Correct? Yes. Next.
Yeah. What do you think about some of the eccentric keratoconus to bring the keratoconus from periphery to the center and make the central cornea more smoother with the help of surface ablation? Whatever way you remove the epithelium is a different thing, and improve the vision from 660 to almost 612 in this country. And even with the corneal thickness is about 460, we did about 4 of them so far. I started learning recently about the NIDEC machine because we did not know what features are there, because the machine is having so many features in that NIDEC machine. What do you, how do you take these matters so that all of us can follow your experience and improve our quality of vision for the patients, not just keratoconus, even the quality of vision?
Absolutely. So again, Doctor, love it. You're tackling keratoconus with laser plastic concepts. I can show you, I'll be running out of time. We have a lot of cases that I want to show you. Here's how I'll approach this. I do not worry about central or peripheral cone. I do not worry about how the topography looks. Let me repeat this. Topography doesn't correlate to vision. Refraction does. So I actually start refracting these patients with my own streak retinoscope. I have every technology in the world they go through, but I do not do anything without streak retinoscoping every patient. So doctor, when you did the laser to move the cone, you indirectly corrected the refractive error. And that improved the vision. That's what I'm analyzing from what you did without seeing your case. That's my experience, period. Now, if you had focused only on the refraction in every case, I guarantee all your patients will touch 20/25, 20/20 in keratoconus. So you've done 4 cases, please do more. 460 microns is too much, is enough. And if I may, I think your refractive error must have had myopia in it.
Yes, it has got a myopia, and the vision before the correction with myopia, it was 6/60.
Correct.
And then after doing these ablations, the myopia got corrected to some extent, not the full. I did only the irregularities and spherical aberration base, which was 18.5 before the keratoconus surgery, right. And it came down to 1.4. The spherical aberration, and the quality of vision, the quantity of vision, everything is improved. I did not do the correction of the myopia because the corneal thickness was not so much, and I did not have so much of experience like you.
So doctor, can I suggest one quick statement so we move ahead with time? Next time, please go for the refractive error. Do me a favor. Again, see, I'm making a statement, but I want y'all not to take that as a box. Don't look at the spherical equivalent, spherical refraction, Q values. First, tackle the mountain. The mountain is the refractive error. If you go and just break the molehills, a little bit of improvement here and there, but the mountain's still standing. So I would encourage you next time, since you already have 4 cases, doc, you already know it works. So now you should be addicted to that outcome, right? How did you feel when the patient saw? Didn't they cry?
Yes.
Yes, that's what I showed you in the first slide.
They are so happy that because they've never seen so well.
So will you, doctor, now accept anybody telling a keratoconus patient, let me cross-link and leave you on contacts? Will you ever agree to that? No, because you've seen it. That's what I'm constantly showing you all. So very important here, doctor, next time, please go straight for the refraction with the laser. Of course, keeping the parameters we discussed. You'll be blown away. Each of them will see 20/20 and they'll bless you for the rest of your life and you'll see that.
I think that will be a good learning thing for all of us.
Absolutely is. Next one, please.
Siddharth, next question. You can share the screen.
If everybody is finished off with their questions, I'll share the screen. Somebody else has some questions?
Yes, Siddharth.
Yeah, please go ahead.
Yeah, Dr. Gulani has driven the nail on the head regarding correcting the refractive error first, especially even in cases of this bad keratoconus. So now just one doubt that cropped into my mind is, for example, if this patient has a corneal thickness of say 300 or 350 microns, and we do a surface treatment and correct the refractive error, patient sees well. But in the event of cross-linking such a thin cornea, how do we approach him after correction of the refractive error on the surface? Because the guidelines of cross-linking have some rationale regarding minimal stromal thickness.
Again, doctor, again, see the point here. You are assuming you need cross-linking in that cornea. Is that correct?
Sir, at when there is an established case of keratoconus, for example, let's hypothetically say this patient is in the mid 30s, like 30, 32 years
Okay.
old.
Okay.
He may be naturally cross-linked to a certain extent, but
That's
once
right.
you are reducing the corneal thickness further, in such a case, maybe say we will have two kinds of outcome. A patient may require cross-linking. B, a patient may not require cross-linking. Now, in the scenario that this patient requires a cross-linking further because he's progressing, then in that case, because the cornea is extremely thin, wouldn't it hamper our cross-linking as
Doctor,
yeah.
doctor, let's move fast, okay? So I'll go through my process again. Again, see, the question you're asking is not wrong, but it again tells me the same disease is going on with the people who are asking the same question. Again, you're stuck in the rhythm of keratoconus, corneal thickness, and scared with cross-linking. Am I correct? That's your diagnosis. Here's how I would approach the case. Give me this case, give me the refractive error, give me the case, and see how I walk you through. Why would I do laser surgery on a keratoconus case when I know I'm going to make them worse? That itself, I'm going to nip it in the bud, right? I'm not doing that technique. Are you with me, doctor? Where are you?
Yeah, I'm getting you, but yeah.
See, I'm constantly forward. You guys are constantly behind and worried. Don't do that, please. See, why would I do laser on a keratoconus knowing that I'm going to bring them to such a level of weakness that I'll be scared of keratoconus cross-linking? Now, first of all, cross-linking corneas. There is a thickness parameter, there's a legal parameter, etc. Absolutely understood. More important, that's what I told you, we'll change parameters in different cases. Dr. Kenya had asked that question. That's another discussion. See, your question is multifaceted, but here's my answer to the logic. If the patient is over 40, astigmatism more than myopia with some myopia, cornea more than 400, go for it, like Dr. Shah did. The K-conus patient will see 20/20, 20/25. Don't worry about topography. You don't want topo-guided stuff here. Just go for it. That patient will not even look cross-linking, but do follow-up every 6 months in case they need it, because you fix the spine. Remember, all the concepts are coming back here. Are you with me? Yes. Let's say this patient of yours, 30 years old, you monitor for a year or two and she changes. Now you rather cross-link her first, provided she was 20/20 on refraction, because that way you haven't spoiled the spine. Then take her to laser or ICL or cataract or whatever you want. You see my point? I'm not thinking cross-linking as a fear. I'm thinking of it as my partner if needed.
Yeah, but that is provided the cornea should always be more than 400 with the epi off, right? Means you all those corneas that will have.
You're again going into the same technical details of how to do it. The epi off, epi on, silly stuff doesn't matter. Go epi on if you want. I'll teach you my technique, which is so simple, guys. Everything I do is so simple. I wonder why you all complicate these things and confuse yourself. And then you don't treat the patient. So if you do epi on, please, first of all, it works brilliantly. I have to leave. And then what I do with a little Vexel, I make a little breaks in the epithelium in the area of the cone. All right, just try that. Whatever you want to call this technique. Break the epithelium without breaking it completely, just like slivers. Just rub it with a Q-tip or a Vexel. Now do your cross-linking. It does very well. And follow your protocol if it's a normal cornea. If not, then other ways I decrease the zone, I increase the energy, all those things I do. My point is, guys, don't worry about that as much as what that patient deserves. If that much is your worry, I would go with an ICL provided she's 20/20. And if she's young, you're not talking cataract. But you see my point. Let's not go back again into what should we do technology-wise. Talk forward. Next.
Dr. Ramesh has a question.
Yeah. Sir, when you make multiple punctures on the epithelium, do you follow the same timing and the power for the same power input?
Yes, absolutely. And again, please, there are aspects to this, the zone, everything I change, and I don't actually puncture, doc. I take a Vexel, like a sharp Vexel, and with that I just rub, and you'll see slivers or cuts in the epithelium, and I keep that mostly in the cone area. That's what I do. Next. So get on the discussion. This is another discussion I don't want you to have. Epi on, epi off, and waste your energy. The doctors are not understanding when to do it. Remember the keratoconus concept I showed you, right? You all remember all that?
Can you, Dr. Gulani, have you checked your effectivity of the C3R with this method on your OCT, where you can find the deeper line which we normally see? Is there a good evidence of cross-linking with this method?
Again, no, I have not. But that doesn't matter to me because the patients are now 11 years, 12 years out and the refraction is stable. Remember again, doc, all these things are great for a conference. Look at my OCT, look at this, but their patients are sitting in my office crying. What I want is the patient seeing perfect. And then I do my topographies and OCTs just to teach colleagues, because that's the language they understand. If I had it my way, you don't need an OCT for keratoconus. Tell me, come on, do you need more than your slit lamp? And again, let me qualify this, please. I have all the technology in the world. What I'm teaching you all is how to be a martial artist. You don't need anything. Just get to work. Pardon me, am I getting through here, doctors?
Absolutely.
You have to be tough. You have to be intelligent. You have to be logical. You have to be ethical. You have to be high empathy for the patient. And your results will be amazing. I guarantee it. Okay, next quick. Now, I have two options for you guys. I have a lot of surgeries and stuff to show you of unique cases. Other than that, I have 5 minutes. So if you have a question you want me to go through or summarize for you, please let me know. What would you like?
So go through your unique cases, sir.
That's a lot though, Vishal. I have to leave in 5 minutes. So
And
that's a lot. Now, does anybody have a pressing question, or should I summarize the whole logic for you? What should I do?
You have uploaded all your videos on your channel in YouTube, I think.
Yes, doc. Everything is up there. All the surgeries are up there, and I can even see if I can.
Some of the thoughts which I got it after seeing that.
Right. Like, let me go through quickly. Can you see my screen?
Yes, sir.
So that's the scar removal, and then 8 years later, a toric premium to 2020. These are intact cases I do. There are various ways of doing it. You can see patient reactions here, how they behave, how they cry. This is intact. This is not laser. Under the laser, as you fix their optical circle, as you see, they are seeing immediately and they start crying. And these are tough people, remember, not ordinary guys. See what he's saying. Right under the laser, he's talking. You can see. Can you see that?
Yeah.
Topography, you can take them down. And doctor, here's the great case for the Dr. Shah, who was doing an interesting cases. Dr. Shah, see how I don't look at the topography. I went to refraction. But the topography indirectly improves, but that wasn't my goal. Let me repeat what I said. The topography improving is a welcome side effect. That was never my goal. The refraction is my goal, always. So you see all kinds of ectasia can be corrected in 6 minutes, guys. The worst LASIK complication you all can ever see can be fixed. Now, after you've done your intacts, it doesn't stop there. You can do laser surgery on top of it. What's stopping you, right? Because you have enough tissue. Cross-linking complications, we are fixing a lot for patients from all over the world. Lamellar techniques, I want all of you all to know. I know all of you are great in this. Even your DSEC, DMAC that you'll do, stop confusion of what you call it. Make it refractively neutral. That should be the goal that no one is trying. Don't call it names. People are like, this is a new name, this is a new technique, thin cornea. You don't want that. Can you get it refractively neutral, please? Yeah, I've been doing this now for 20 years in RK cases, sutureless DSEC techniques. It's so easy. All of you can do this. Refractively neutral. That's the point. Osteoepicariophakia cases can be corrected. Now I'll just go through faster. Phakic implants. A lot of these patients fly to me. They've had premium cataract surgery somewhere in the world with good surgeons, and they're unhappy because the doctors missed the mark of vision. They just put in the technology. How many of you see these kind of cases? All the time, right? The problem here is that doctors are constantly giving value to the lens, not to their own ability. That's wrong. So you see how that can be fixed to trace the major issues. See the sequences of cases you can take to doctor. This is where I was insisting that I want doctors to remove epithelium manually, because that's how the scars will be tackled. And it becomes so easy understanding that concept in the future. You can see these kind of cases. This patient came from Switzerland, very high myopia, cataract, keratoconus, high keratometry. I first put in the rings, and then I went in and put in a toric lens. Again, sutureless, topical, important, please. Keep the ambience. If you've seen my lecture now, you understand everything I want all the time, not 1 or 2 cases. You want it. And the patients, here's a patient who had 12 failed procedures. Dr. Shah, you would love this. Keratoconus patient with PDK, PRK, scarred cornea, keratometry irregular, intacts in place, cross-linking done 4 times, ICL in place, cataract, comes to me with 2200 vision. What would you do, doctors? Again, for time, I'll just go through quickly. So many page doctors who saw him were talking transplant because he had major surgeries. Your doctor did intacts badly. Your doctor did this badly. They're going on and on. Doesn't matter. Doesn't matter. To me, at least the doctor had put in the rings, though improperly, but made it stable. Remember, I want stability. As long as it's stable, I went into the eye, removed the ICL, as you can see here. Remove it completely as it was, through the same incision of the previous surgeon, then remove the cataract. Now I stopped and I did not put the lens in. This is the technique I do where I leave them aphakic for a week and I refract them. And when I refract them, I get an accurate refraction. Then I use my piggyback lens formula. going to perfection. You want, again, your confidence, toric premium implant, straight to 20/20 vision. Are you guys with me? So please don't even, I know all of your experience, you'll see complications, patients from others, but don't just stop it. Top it. Top it. Take that mindset. That's all I want you all to have today. Any questions for me at all?
So just one last question, we should sum it up. Stop your screen sharing, and there are a lot of questions, but there's just one, and that we'll just get to that. Yeah. Dr. Gulani has no limits, but in the end, what are your cutoffs, sir? What are the limits for Dr. Gulani? When would you do a keratoplasty? You don't like doing a keratoplasty, but which would be a case where you would be forced to do a keratoplasty? I want to ask for the the maximum correction you like to do with establishment of LASIK. What are your maximum limits? And what are your minimum residual stromal beds for LASIK and PRK? You think out of the box, but which are the things which actually stop you?
Now, I will see if my time was worth it. Siddharth, you will answer these questions. Let's go. When would I do a PKP?
Okay, when would you do a PKP? PKP would be option Z, when option A, B, C, and everything. PKP would probably be your option Z when all the other options are off the table. So when is
No, doctor, you learned from me today. I do not have plan B ever in life or in medicine. That's what makes you confident. If you have a plan B, you will fail. Can you please remember this?
True.
And please pardon me, I'm being direct for lack of time, but I want you to get this mindset. The only situation, I said this in my talk, when I do a PKP would be, God forbid, a perforated cornea. That's it. Otherwise, I will still struggle to do a lamella like you saw me do in that oral surgeon, even with his RK cuts. But more important, doctors, I call this course, when I teach, I call it arrogance for vision. Arrogance for vision. You have to be arrogant to yourself. That's your sign of commitment. That even with that kind of deep cut in an oral surgeon with no future, with scarred, with 15 diopters, you saw that video. I went in and did a lamella. I refused. So now he plays golf. Both his eyes are done, and he's 20/25. Next question. Maximum correction for surface ablation LASIK. Doctor, you already understood from me. There is no maximum millimeter from me because I choose what is right for the patient. All right? Where are you? I don't see you guys.
Yeah, I'm yes.
Yeah, but you said that beyond 8 diopters would not be good for surface. I think that's what you mentioned.
What is that?
Beyond 8 diopters would not be good for surface. That's what you just, I think, said about the physics.
Optically. Doctor, understand the whole statement. Optically. Now, if that patient had, let's say, let's just give it a silly example, extreme. Let's make it -9 diopters. But the patient has a central scar and the keratometry is around 44. Let's give that. All right. And I have to plan a cataract surgery in the future. In this case, I would go even -9 because this patient is not a 20/20 patient as a virgin young LASIK patient. I'm not only clearing the cornea, I'm correcting the keratometry and I'm getting all the -9. I will go all the way. Residual corneal bed, at least 350. Because the cornea is normal. In fact, see how everything I say has a facet. The scar actually makes the cornea stronger. Are you with me?
Yes.
Guys, did you get it? Minimum are, that's again your thing. Stromal thing, again, back to the same thing. There is no such thing. It has to be a safe and normal cornea. Don't go below 350 if required. I've even gone to 200 in a herpes cornea because for the scarred cornea, patient is now 12 years post-op, still seeing great. Remember, again, this is not about bravado. It's not about having limits or not having limits. It's about logic and safety. I don't want you to walk away today with, I want to do what Dr. Gulani does. First, you have to plan the empathy part of it. Do you really care for that patient so deeply? Second, you don't give options because you're planning the right thing. Third, you have to have the skills to the artistic level, at least, that you're doing surgery. And if you think for a minute, if you do surgery and you're not letting the patient see in the stage 1, you failed already. Am I right?
In case of Dr. Gulani, you said that you do the hyperopia at about 9 millimeter to avoid the regression. That is what you said.
Yes, correct. Yes. Again, many aspects of that, but yes, the ablation should be a 9, correct.
Okay. Can you tell us how much extra ablation you do? It may not be important, But for the academic point of view, how much extra ablations a person has to do when you shift from 7.5 or 6.5 to 9 millimeter of the zone?
Again, doctor, that is not important here. Here is why. If you look at the laser, take an average laser, okay? I've used all the excimer lasers. Let's take average laser, 16 to 20 microns per diopter. All right? Now, the first reason I said this is not important is you're working in the periphery where the cornea is pretty thick. So it doesn't matter. What is important I'm trying to say is that 9 millimeter zone, doctor, is the hyperopic profile of most lasers, even though there are some like Nidec has an excellent profile coming from in-out, or the Schwinn has another profile. But if you don't think about it as the intricacies of technicality, think of it as the logistic appearance of how 9 millimeters helps you. And now, again, where this helps you in your future is when you do RK cases. That's why those patients get blown away when you do surface surgery on post-RK, which are usually hyperopic. So that's where I'm trying to go with this. The logic, once it's understood, everything else will become easy. Very important. All right? All questions done?
Yeah, all are done. All questions, all major questions are done, sir.
Everybody's going to change from today onwards?
Surely.
Absolutely.
Dynamite?
Yes, sir.
No routine, no rushing through patients. I want perfection with everybody, guys. All right?
Dr. Vaishal, would you like to give the vote of thanks? Swapnesh should not you.
Yes, yeah, certainly. I would invite the secretary BOA, if he's around, Swapnesh, to give the vote of thanks.
Swapnesh doesn't seem to be around, so you
okay, fine. Sir, it was on behalf of Dr. Lane and Dr. Ragini, I would like to thank you for gracing our invitation and at a very short notice accommodating us and giving a brilliant talk, and it was very insightful and thought-provoking for us, and definitely planning, making the cornea measurable, stable is the key word which you have taught us, and definitely our way of thinking would definitely change. And next time, whenever you come, I assure you a physical meeting, and because of COVID restrictions, we had to keep an online meeting this time, and that would be more interactive, I understand. And whenever you feel you want us, we can have a Zoom meeting from USA also. It's really insightful to hear you. Thank you so much, sir.
Well, it's my pleasure, and more important, again, in summary, I'm here for you guys, anything you need. Take all the logic, do nothing for the next 1 hour. Just remember what I said, because if you go back to your silly residual bed thing, I'll get very angry with y'all. No showing white cataract nonsense. All of you should be 100% in that. No still worrying about Argentinian flag sign nonsense, things that you'll show each other. Lenses dropping. Anybody tears the posterior capsule, no surgery for a month. I want you to be strict on yourself, guys. If you don't do that, you will be very charlatan. You'll be, oh, I tore my capsule, but the patient's seeing great. No. I want you to go back in the mirror and go, why the hell did I do that? Cannot do it. So I agree, we are all human. Things can happen. But I want you all to be very strict on yourself, and then I guarantee, just see how your life changes. You won't be rushing through a patient. You'll be enjoying this process of how you're planning. You've seen me plan, right, in the videos on my YouTube. I sit with them, explain, plan, and they become your partner. That's when the fun starts. Now you still have to perform the surgery. So the biggest lesson for today is, guys, all of you are brilliant surgeons. I'm not talking about surgery, but change your mindset now. No having conferences on silly things. What would you do? What would you do? This is what the patient deserves. Can I do it? Can I do 40 techniques? If I cannot, I'm not even at surgery level. Can you guys do that?
Absolutely.
I want perfection from all of you, and anything you need anytime, guys. You'll have my email. You'll have my phone. Just call. Love you all. All right?
Hey.
Take care.
So thank you so much, sir.
My pleasure. Bye-bye.
Yeah.
Thank you.
So thank you, Ramesh Bhai, Siddharth, and Dr. Nitin Balkrishnan for, it was an amazing meeting, interacting with you all, guys. And thank you, all of you, for attending this meeting. Thank you so much.
Thank you.
Yeah.